on Health and Human Services. We'll be having one bill for a work session, and then we'll be hearing several other bills this morning as we work through our calendar. Let's start with, you can join us on video too by going to our YouTube channel. You can find that by going to legislature.maine.gov and looking for HHS, Health and Human Services. That will take you to an option to click on the YouTube link so you can watch and listen at the same time. We will be having some testimony, and we'll be letting folks in as we're ready for that. And then we'll start first with LD 118 and then go through the list as published on the 10 o'clock, starting with 496. So let's start with introductions, and we'll begin with Representative Griffin.
Good morning. My name is Abigail Griffin, and I represent House District 102, which is Glenburn, Levant, and Kenduskeag.
Representative Connor is here.
Thank you, Mr. Chair. Good morning, all. My name is John Connor. I represent House District 58, which is part of Lewiston.
Representative Craven.
Thank you, Mr. Chair. My name is Margaret Craven, and I represent House District 59, which is part of Lewiston.
Representative Madigan.
Good morning. I'm Colleen Madigan. I represent House District 110, which is part of Waterville and part of Oakland.
Representative Lemelin. Whoop, can't hear you. There we go.
There we go. Good morning. I'm Michael Lemlin. I represent House District 88, Chelsea, Jefferson, Whitefield, and half the Noble.
Representative Stover.
Good morning, Holly Stover. I represent House District 89, including Boothbay, Boothbay Harbor, Southport, Edgecombe, West Island, and part of South Bristol.
Representative Perry.
Good morning, I'm Ann Perry. I represent House District 140, which includes Indian Township, Baileyville, Bering, Calais, Charlotte, Robbinston, Perry, Pembroke, and Pleasant Point.
Representative Javner.
Good morning, I'm Representative Kathy Jabner, and I represent House District 141, which is located in Penobscot and Washington County.
Senator Moore.
Good morning, I'm Marianne Moore, and I represent Senate District 6, which is all of Washington County, as well as Goldsboro, Winter Harbor, and Sullivan in Hancock County as well.
Representative Meyer.
Good morning, and thank you for joining us this morning. I'm Representative Michelle Meyer, serving House District 2 here in Southern Maine, which is all of Elliott and parts of Kittery and South Berwick.
And I'm Ned Claxton, representing Senate District 20, which consists of Auburn, Minot, Mechanic Falls, Poland, and New Gloucester. We also have our key staff today here. Ms. Broom, would you introduce yourself?
Hi, I'm Anna Broom. I'm one of the legislative analysts for this committee, and I work in the Nonpartisan Office of Policy and Legal Analysis.
And Ms. Withy.
Good morning. My name is Carrie Withy, and I'm the clerk for the Health and Human Services Committee.
All right. And to start our day, will be, did you have your hand up, Anna?
It was an accident. It's next to the chat, and I hit it by accident.
Okay. All right. So let's start with hearing about LD 118, if you would. Oh, we're joined by Representative Dr. Zager in his scrubs. Want to introduce yourself, sir?
Oh, well, thank you, Mr. Chair. I will be here for as long as I can. My name is Sam Zager. Honored to represent District 41 in Portland.
Glad you could join us. Other folks who aren't here are busy, tied up in other meetings or other committees. I'm going to have to step away at some point to do some testimony in another committee. So let's start with 118 then.
Okay, so I'm going to share my screen. I'm just going to go through my bill analysis. You obviously got a lot of other documents that I'm also happy to share the screen, but all the folks that provided those other documents are here. So you may want to hear from them directly. That's up to you. But I will share my screen first of all for hopefully you can see that. So So LD 118, an act to address main shortage of behavioural health services for minors. I did summarise the amendment that you received at the public hearing rather than the original bill. So this bill requires the Department of Health and Human Services to collect data on the number of children with behavioural health needs remaining in hospital emergency departments for extended stays, the length of the extended stays and the reason for the extended stays, and post the data annually on a publicly accessible website without any information that may directly identify any individual child or family. The department is required to submit a report to this committee with that annual data compilation. It also requires a second piece. The Children's Cabinet is required to convene a stakeholder group to develop a plan to address the barriers to appropriate levels of care for children remaining in the emergency rooms awaiting services, and report that to this committee by February of 2022. So you heard at the public hearing that the sponsor's intent is to collect data and develop a plan to solve the problem. And she presented some other options for the stakeholder group. You heard some opposition from the department that the building capacity of the Children's Behavioural Health Services is the means to fix the problem of children remaining in emergency rooms. And the department is working on that with new services, the QRTPs and the Appendix D rate study. And there were concerns about privacy with the small number of children. You heard from a number of proponents about things such as Long Creek being a default provider of behavioural health services, insufficient funding for home-based services that's also contributing to lack of slots, closures of programs and increasing wait lists. And you heard from Northern Light and Maine Health about the number of kids on waiting lists for inpatient and outpatient services. So I did attach the language from the sponsor's amendment to the email that you received yesterday. So there were a number of sort of small things related to that, drafting issues on that amendment. The first one is related to the data. This is a small point, that the data collected and posted on the website and the data in the annual report to the committee are slightly different. And I'm not sure there's a reason for that. I think it's just sort of a drafting error. The annual report to the committee doesn't include the reason for an extended stay, which, by the way, is lack of appropriate placement or lack of community services. It's not a diagnosis. And also, does lack of appropriate placement, does that mean inpatient to the 4 hospitals, or does it mean something different? Residential care, I'm not really entirely sure. The stakeholder group must collect data for at least 1 year, but the bill wouldn't go into effect until 90 days after adjournment, and that report is due in February 2022. It seems to me that there's quite a lot of data already collected, so you could probably use retrospective data that is already available, but it's not written that way. That's my fault, presumably. And I don't know if February 1st, 2022 is actually early enough to report out a bill in second session. As you know, second session is short. It's also a little unclear who's writing the report. The Children's Cabinet convenes the stakeholder group, but the stakeholder group submits the report, and that's a little unusual. So you did request a lot of additional information. So you asked for the recommendations from the LD40 Children's Mental Health Study. We have both of the chairs of that group on this committee. And there were 2 email attachments from the department. One was the LD40 response, and also the Children's Behavioural Health Update from December of 2020, which you had received before. You asked for the number of children that are impacted and the average number a year of children who are stuck in ERs. Is it also any information about length of stay and the number of children moving around the state and going out of state? And you received a memo from the department, which we can you can talk about shortly. You also received some information from Sarah Calder at Maine Health, and I see the Maine Health folks are also on the list of participants. Sarah said we don't keep wait lists like Northern Light Health, but this, so it won't be exactly apples to apples, but Maine Medical Centre and Maine Behavioural Health Care, a child or adolescent requiring an urgent outpatient appointment can wait over 2 weeks for an appointment. The wait is 1 to 2 months for intermediate acuity, and a general behavioural health visit can be a 6 to 12 month wait. And you also received an additional PowerPoint that I couldn't just paste in, so I attached that and sent that to you. And then Northern Light, this is from Lisa Harvey McPherson. She said that Acadia Hospital has 8 to 19 kids waiting for admission to an outpatient bed every day, and Acadia Hospital has 500 kids on wait lists for outpatient services. For 2020, the following is a total of child and adolescent patients who were in Northern Light Health's emergency departments for over 72 hours awaiting a disposition, and she didn't identify the hospital. So you can see that data there, and I'm sure that Lisa is here as well. The fiscal impact statement, this is based on the original bill. I don't know what exactly the changes would be. We'd have to ask Luke for that on the amendment, but that would depend on what you decide to vote for. So the original bill, the department would require a general fund appropriation of $173,000 in fiscal year 21-22 and $108,000 in fiscal year 2022-23. And that's for a position, a social service program specialist to design and implement the reporting system, outreach hospitals, troubleshoot data issues with the hospitals, and engage the appropriate behavioral health program coordinators to work with the hospitals to discharge children. So remembering that the original bill had the behavioral health program coordinators piece in it, and that is no longer in Representative McCrate's amendment. That doesn't necessarily mean it doesn't require a position. I can't weigh in on that. And then the other piece, which you've seen many times, is the one-time technology part associated with creating a portal for data collection. So that's a one-time cost. That's why it's more in the first year than in the second. So I don't know how you want to go about looking at all of the pieces from the department. I'm sure all the folks are here, and I'm happy to share the screen at any point, but it's up to you how you would like to approach that.
Let's start with questions from the committee, and then we'll go to Representative McCrate for her response to the analyst report. Thank you, Anna. So are there any questions coming from the committee about that analysis from Anna? I don't see any. Okay. So, Representative Stover, is that a hand?
Yeah, I don't know if it's an appropriate question at this juncture, but I'm just wondering if Representative McCrate, in some of the data, I know that we're talking specifically about long stays in the emergency departments. We're talking about children with behavioral health needs in need of placement, and whether or not in that discussion, and maybe it's a Representative McCrate and a Molly question, about would we be including those children who have had to go out of state and what that could mean for them returning back to this state in part of that larger discussion that if OCFS and the department's going to discuss this sort of this whole issue, the whole bailiwick, possibly including those out of state children, because that comes up as frequently in this bigger discussion. I don't think that was phrased in the term of a question, but it is a question. Thank you.
Representative McCrate, welcome. Did you want to respond to that now? So you're unmuted?
Of course, I was muted. Thank you, Representative Stover. Yes, the kernel of the idea was around kids who are stuck in emergency rooms, but clearly to me, that's a part of a much bigger issue. So in the amendment that I put in, what I'm suggesting is we have to look at the whole enchilada. We've got kids in emergency rooms. Why are they there? Why are they stuck there? I want to look at what are the gaps and what are the barriers. So, I mean, I could make all sorts of assumptions about if we had better home-based services to prevent kids going into crisis, if we had better crisis or more access to crisis, if we have a lot of the programs we don't have anymore, case management, partial hospitalization, those kinds of programs that prevent the problem in the first place, hopefully. But for those who do need care, we have more robust access to care, outpatient, inpatient, residential, meaning group home kind of care. And kids out of state, my assumption is that if we have the appropriate levels of care here, we're keeping kids in state, close to family, close to community. So community-based, hospital-based, residential, outpatient. What is it? But I think we need to target you know, what's the best, what do we need most and what do we need most now, and then build out from there. So that's where we need robust data, robust discussion about what's making this happen. I know work has been done, but we need to pull it together. We need to act on it.
Representative Craven, you had a question?
Yes, thank you, Mr. Chair. So I don't see any breakout at all from St. Mary's and Lewiston, but I'm assuming that the numbers are included in the department numbers that we got in their memo for an overall count of the hours and the wait on the wait list.
Are you asking me?
I'm sorry, I'm Representative Jabner, you're talking, but I'm not hearing you. Okay. All right. So we'll put that on a list of questions to get answered before we get too much further along, Representative Craven. Representative Javner, did you have something?
Thank you very much, Chair. Yes, I'm very interested in hearing from the sponsor. You know, I read the Children's Behavioral Health Update report from December 2020. It seems very all-encompassing. I mean, it's amazing what they've been able to do even in just this last year. So I really want to hear what it is that the sponsor is looking for, that this bill is going to produce for us that is not already in this report that we are receiving from the department.
Thank you, Representative Javner. Well, I have a couple answers. One is we still have the problem, so we haven't solved it. The fact that there's some data, that's great. Let's build on it. But the data is only a piece of what I'm suggesting here. We need clear data that's accessible and, of course, confidential in terms of kids, families, even the hospital, because we have a lot of small hospitals where it could be identifiable. But then let's take it and act on it. So as I just described to Representative Stover's question, let's use data, let's keep collecting data, let's see that we're improving, let's see that if we're not, let's see how we make the appropriate changes to reduce the problem that's incredibly significant. And if I could suggest to the committee, Dr. Tweed is here and a great expert, has been working on this with me from the very beginning of this kernel of an idea that we need to address this in a different way. So when it's appropriate, I would suggest that he could be very helpful.
Representative Javner, did that answer your question?
Yes, thank you, Chair. It does begin to answer my question. Again, I just will say that, you know, for looking at quantifiable data and what has been occurring for positive motion here for the department and for this issue, I think that perhaps, you know, there's going to need to be a little bit more time to see actual positive results come from what the department has already, you know, putting into place, and the obvious, you know, the heightened level of where they are placing this issue is clearly seen in their report. So it answers it in a question, you know, on one level, but yes, I'm very interested in hearing what Dr. Tweed, you know, has to say concerning this as well. So thank you, Chair. Appreciate it.
So let's go to Representative Perry and find out what her question is, and then we'll go to you, Dr. Tweed. Representative Perry?
Thank you. Yeah, I'm actually looking at figuring out how we best can do this, because quite honestly, the amount of time spent in emergency rooms for mental health issues is sort of like the steam in the pressure cooker getting ready to go. Measurement helps us, but it doesn't help us unless we have an action plan to release the pressure. And I think that, and I'm just going to ask this because my question is, I'm not sure this belongs with the Children's Cabinet. I think this belongs in a place where you need the expertise to really sort of look at the whole picture. And so I'm asking why the Children's Cabinet.
Representative McCray, did you want to speak to there as opposed to someplace else?
Sure, thank you. Thanks, Representative Perry. You know, I'm open. It's been suggested to me, just as you were describing, that perhaps the better place for this work to happen is with the Office of Children and Family Services. And of course, it's the will of the committee. My goal is that it happen. And if that's the better place, I have talked with a couple people around this idea, and key to me is that all the players that I listed in the amended bill are involved. And I'm assured that all of those people would be involved. For example, we have kids who come into the emergency room in crisis and they end up at Long Creek, not the appropriate placement for them, but that's where they end up. So Department of Corrections needs to be involved. And I'm assured that there is a close working relationship and that the behavioral health experts, the hospital emergency room experts, the corrections, the department people would be involved. So at the will of the committee, I'm open. I just want us to get to that action plan that we've talked about. We need to change. And I agree that it will take time. We're in quite a situation that's going to need a lot of effort. But unless we focus in, unless we get regular updates, report backs to this committee that has oversight, we're not going to know. So let's do that. And the other that I would just add is the report on the work group just came out. So we didn't have that available to us. Notwithstanding that, good information, use it, but keep going.
Okay, Dr. Tweed, thank you for joining us.
Thank you, and honorable chairpersons and members, thank you for allowing me to participate. So those were some great questions, and that I'd like to try to address. One member asked about out of state. Not that many kids go out of state hospital. There are a number of kids in out-of-state residential. Now, the department and the Office of Child and Family Services, OCFS, is doing a fantastic job posting how many kids are in out-of-state residential. Not that many departments would do that. That's really fantastic. That's a great metric overall for our system of care. And congrats to the department and OCFS for doing that. And we would love to extend that transparency to the problem of extended youth stay in the ED. One of the members asked about St. Mary's. Actually, St. Mary's doesn't take aggressive kids. They're paid in a different way than Spring Harbor and Acadia are paid. So they have always said, given their payment mechanism, they're not able to handle aggressive kids. You know, one of my hypotheses, and you know, it's the department's, we'll come back to this. The department is doing a great job building the community system of care, and that is incredibly crucial. And we're super big supporters of Dr. Landry, his talented team, and the department's overall approach to that. There is a problem. Spring Harbor will say a lot of times the kids who are stuck in the ED are kids with behavioral health problems and aggression. That's what gets them stuck there. The kids with suicidal ideation, they pretty much get whisked right in. But one of that reasons, a lot of times Spring Harbor will say, okay, we'll admit that child, but they have to go to a private room. We have 4 private beds. Or Katie would say, we'll admit that child, but he needs a one-on-one. And we generally speaking, have a limit of 5 one-on-ones. We probably only have a capacity statewide in our 2 hospitals of about 9 for kids with behavioral health problems and aggression. And a lot of them are filled with kids waiting for residential. So maybe that's too much weeds. That's a little bit of a hypothesis from me, and I'm sorry, I meant to say, I'm president of the Maine Council of Child and Adolescent Psychiatry, and I'm representing MCAP today, but that's a hypothesis of MCAP. But we really need the data to really confirm or disconfirm our hypotheses. One of the members pointed to the excellent report that OCFS put out, the annual report. That is a great report and a great plan, and it talks about improving a very complicated and complex system of care. Now the thing, and we're again, I can't say enough, we're big supporters of the Department of an OCFS, of Dr. Landry and his team in these efforts. The thing is, it's a complicated system. The current reform might not nail it right away. You know, changing complicated systems is hard. It really needs to be iterative. You know, in healthcare, it's called plan, do, study, act. You know, we make an intervention and then we see what's getting, you know, what's getting better or not. So we would put out that this is one of the excellent metrics. You know, how prevalent is this, you know, extended stays in the ED, along with, as one of the other members pointed out, kids in out-of-state residential. That's another excellent metric. So again, we're big supporters of the system of change initiatives underway, but we have to look and see if they're working and if they need adjustment or not. And this will be a great baseline. The same member said, well, there's not enough time. That's right. This would be the baseline. Yeah, and then one of the members talked about the ED as a pressure cooker, and again, that you know, when the system breaks down, a kid gets stuck in the ED. That's one of the things that makes it a great metric.
Are there
there are other things that I could say, but I think at this point it was just to respond to the members' questions.
Yeah, are there questions from the members of the committee at this point for, say, Dr. Tweed? Yes, Representative Javner.
Thank you, Chair. Thank you, Dr. Tweed. Appreciate you being here today with us. You know, we're all very concerned about this issue. And one of the pieces that really strikes me is this increase in the aggressive, you know, behavior in the children that we are facing now. What have you seen in your professional life and experience with the increase? And what, obviously we all know, I think going forward, what do you think the increase is going to be? What are we going to be looking at as a state?
You know, there are many background factors that are risk factors that increase that. Childhood poverty is a risk factor for that. Certainly parental mental health and substance use disorder problems are, you know, a lot of these are referred to as adverse childhood experiences. So those are all real, you know, those are all drivers, and I know you all in other bills are trying to address those society-wide drivers. As far as us in the children's behavioral health system, there are evidence-based practices that have been shown to help preschool and grade school kids who are starting to develop problems with emotional dysregulation, which usually comes out as anger, discontrol, and aggression. Actually, Dr. Landry and his team just put out basically a funding initiative for training in one of the major models, and we're hoping his team puts out funding for training in additional models. So we think CBHS, well, Children's Behavioral Health System Services, part of OCFS, is on the right track, and we're really supportive of them. We just want to measure the outcome.
Thank you.
So I'll ask a question, Dr. Tweed. This feels a bit measuring the kids who are out of state and the kids who have stayed in the emergency room and how long, feels like a pretty downstream metric to measure a process with multiple complicated steps before. Would there be better metrics further upstream that we could use to measure how we were making progress in this? Because if it's all dependent upon things we can't do quickly, like increase the number of beds or things like that, this number is not going to stay stuck.
Certainly additional metrics. I wouldn't say better metrics, because you know, when your system can't serve a child and they've got to either warehouse them in an emergency department for 2 or 3 or 4 weeks or send them out of state, you know, again, problems which predated this administration. I mean, that's where the rubber meets the road. Actually, the department is, OCFS is right now, posting the number of kids receiving evidence-based practices. I think that's a very good interim metric. You know, they put it out there even though the number is small. I mean, it was very brave on their part. Of course, they inherited that small number. But I think that that would be a good one right there. Also for this, so number of children accessing evidence-based practices. And then when we implement them and take them out of the research settings where they were developed and put them into our communities, we need to make sure that they're actually working as they were designed. And for instance, the state of North Carolina, it has been disseminating a number of the same evidence-based practices that our department is interested in, and they are doing a great job of posting their actual results of those practices. So I would say access to evidence-based practices as well as the results that we're achieving here in Maine.
Thank you. All right. Are there any other questions we want to ask of the sponsor or of Anna at this point? Representative Perry.
Yes, one thing that comes up that I'm just thinking about is the look at wait lists. Now, I know we do that for disabilities, but do we have anything that has wait lists that really looks at pediatric mental health issues?
So that would be a good question to put to Director Landry, along with a general response to the analyst report, if you heard that part, and to the comments that have been made so far. So welcome, Dr. Landry.
Well, thank you very much. Happy to be with the committee, and thank you for the opportunity to be here. And for those of you who celebrate the holiday, happy Easter. And so allow me, if I can, I will try to be as brief as possible while trying to answer some of the questions. And first of all, I would like to say thank you very much, Representative Javner, for taking the time to read the December report. We appreciate you taking the time to do that and appreciate your comments. When I came to the state less than 2 years ago, one of the things that I recognized is, in my opinion, the previous administration, the past 10 years here in Maine before the current administration, I believe it wasn't just neglect of the children's behavioral health system. It is my opinion that it was active dismantlement, including, I might say, by some who are now testifying, complaining about the system, which I find terribly ironic. But nonetheless, we have to rebuild that system. And with partnerships, with input from providers, families, youth, hospitals, and others, last summer, I should say the summer of 2019, we developed 13 specific strategies to improve the entirety of the children's behavioral health system. The pyramid that we have shown, and I'm happy to put it up on screen if the committee would like, the pyramid shows all of the different levels in order to create a healthy children's behavioral health system. We have to address all of those components, and that is what our plan does. But to, I believe, your point and others' points, it is not going to be able to happen in a year and a half when it took 10 years to dismantle the system. I appreciate the comments about the improvements that have been made. We are committed to making those improvements, and to some of the comments that some of the others have mentioned, we have put out new funding, new training, new opportunities to expand capacity, all of those pieces. And we will continue to do that. And fortunately, with new federal funds, we're going to be able to do even more of that in the coming year. So as it relates to reporting, the previous individual that discussed this is correct. We have put out a lot of information on our dashboard. If you haven't been to our dashboard, I encourage you to look at it. Representative Perry, it has all of the information disaggregated by the types of wait lists, by county, by length of time waiting. It's got all of that data right there, and it's updated on a monthly basis. That information is there for everyone to see. We're being completely transparent, and that's a hallmark of this administration, in my opinion. The reason we don't post this data is twofold. The data specifically around children waiting in ERs. And as I've indicated before to the committee, we collect the data. It is on a voluntary basis from the hospitals, just as this bill would be, because there's no way for us to enforce the data aspects related to this bill. We collect the data. We don't post it for two very good reasons. One, there is no way for us to independently verify the data. Everything else that we report on the website is independently verified by main care data, by census data, by other vehicles. We don't have anything that we can independently verify the data. That we may be able to put a disclaimer on and get by. The other piece, though, is much more challenging. If we are going to be consistent with the other reports and report this information on a monthly basis, the numbers in many cases are so small that it risks identifying the youth. I am very disappointed and disturbed by the fact that what Maine Health provided to this committee includes such small numbers, including locations of hospitals, in some cases reporting one child on the report you receive at a small community hospital has, in my opinion, violated confidentiality. That is something that OCFS will not do as long as I'm here. We can't do that. So that's why we don't report the data. It's not because we don't want to be transparent. We have proven our transparency with our other reports. But I'm not going to report a number out there for one child in Franklin County and risk that child being identified by their schools, by their teachers, by their classmates, by their neighbors. Not going to do it. So that's why we don't. But on a more positive piece, I do want to point to our plan. I do want to point to our report. I do want to point to the improvements that are being made. But I also want to tell you two final things as it relates to this bill. We will do whatever the legislature passes and the governor signs as far as any directives. But what I will say is that time spent, there is the potential that time spent on another task force is time that our staff can't spend actually fixing the issue and implementing the strategies that we have clearly articulated, identified, and are moving forward with. The final piece that I will say, and I just want to make a correction, and I'm sorry I don't remember which individual indicated this on the committee, is someone said that you just got the LD40 report. I want to be very, very clear. There was no report that came out of LD40. What we provided you was the OCFS response to the draft recommendations of LD40, but that was never actually formalized into a report. So I want to be very clear. That's just our OCFS response to that LD40, not a quote unquote report from the LD40 Commission. Possibly a technical piece there, but something that I wanted to point out. So again, my thanks for allowing me to provide this information to you. I am happy to answer any specific questions that you have regarding any of the data that we have provided the committee in relation to 118 or that's on our website or in our annual report. Happy to answer those questions, and thank you for the opportunity for me to share some perspectives.
Thank you, Dr. Landry. And I want to verify that LD40 did not have a report out. As chair of that committee, I own that responsibility. There were some issues that came up, but it's still on me that there should have been a report. And we showed them a draft, and what you saw was the response to a draft of some recommendations. We focused on a number of different areas in that work group, and that included the wait lists, access to care in a community. The biggest overarching one in many ways was the staff shortage, and looking at alternative crisis services that might be helpful, as well as community-based services. So it's a real tightly woven spiderweb of things that need to change and would change gradually. Representative Meyer.
Yes, thank you, Mr. Chair. I'm wondering if we could bring up Katie Harris and Lisa Harvey McPherson to address some of the comments about confidentiality and reporting, and also to remind the committee about the extent of the problem as they are seeing it in their hospital system emergency rooms.
Okay, before I do that, though, I want to recognize Mary Jane Krebs, who joined us a bit ago, and see if there's something that you'd like to contribute to this conversation. Welcome. As soon as you're unmuted. We're not hearing you.
Sorry about that. I appreciate what Dr.
Would you identify
Land-
yourself, please?
Yes, I'm sorry. Mary Jane Krebs, president of Spring Harbor Hospital. And I've had a number of discussions and meetings with Dr. Landry and appreciate the report. I have not had a chance, I just received it, so I haven't had a chance to review it. And I appreciate the long-term plan that he is addressing, putting in, looking at the evidence-based practices, addressing those early childhood experiences that often lead to children being stuck in our EDs at Acadia Hospital, at Spring Harbor. It's really in the short term, what are we going to do? And it still doesn't feel to me like we have a comprehensive approach. We've been, Spring Harbor's been here for over 20 years, and we've had some short-term fixes, and then the problem gets worse. I agree with Dr. Landry that things have been dismantled over the years, and it takes time to rebuild it. Spring Harbor, I want to correct something Lindsay Tweed said. Spring Harbor doesn't just limit, if they have 4 private rooms on a unit, we don't just limit those beds. What we do is we end up taking more beds offline and take those, we look to take those most acutely ill children. What happens at Spring Harbor is they then get stuck there, and they are waiting. There are not the appropriate residential settings in the state. We go through a process where each residence has to reject that child. So the length of time goes up that child is stuck here and more than likely waiting for an out-of-state placement, many of which have been closed to the state of Maine now because of COVID. So then children get stuck in the ED. So it's a continuum of, it's a continuum of care that is broken. And I appreciate there's long-term plans, but I think we also have to look at what's driving, what are the issues with the short term? And is there a way to look at this data in a more comprehensive way? Not every child waiting in the ED is waiting for an inpatient bed. Many are, but not every child, and many of them need the more secured residential that we don't have, which I understand from Dr. Landry will be coming online. It just seems like there's a need for that comprehensive look at the data. And I think hospitals would submit their data if there's concern about the accuracy of data so that the department has that whole picture. Thank you.
Thank you. We've also been joined by, let me see here. I see Sarah Calder or Lisa Harvey McPherson. You were in first. Did you have something you wanted to contribute here?
I want to echo what you heard from Mary Jane. The system is stuck. On any given day, there are 8 to 19 kids waiting to get into Acadia, but there are kids in Acadia who can't be discharged because there aren't the community-based residential treatment services that they need. Then we have kids coming into the ED and they're stuck. The whole system is stuck. And I appreciate the report from Mr. Landry and the vision of the department. There is tremendous investment that needs to be made. But if we don't have even a short-term focus on this issue of kids in the ED, we really won't be able to measure off that baseline if we're making progress. If a year from now, we're still working so very hard investing in that infrastructure that Mr. Landry spoke about, and we're still having kids in the emergency room for 3 days, weeks, and months, we haven't moved the needle. And I think the emergency room data set is an important bellwether on whether or not ultimately we're improving that throughput, making the progress, and having kids in the right setting at the right time. And the ED is not the right setting.
Thank you for that. And I also see that Sarah Calder has joined us. Did you have something you wanted to contribute, Ms. Calder?
Thank you, Senator Claxton. No, I would echo what Lisa and Mary Jane shared as well. And I would just also mention that Katie Harris for Maine Health is here as well today.
I'm just trying to recognize people as they come in, and it's impossible to tell on this screen. Katie Harris, would you have something to contribute?
Thank you. I would echo what you've heard, and I would add that to Mr. Landry, that we take confidentiality incredibly seriously. And if we thought that children in any way were being jeopardized by providing the committee with the data that it had requested, we certainly would not have provided it. I think that our data suggests numbers that are significantly higher than those that the department has provided. So there definitely is a need to work collaboratively with the department to ensure that the department has accurate data related to the number of kids that we're talking about. Just in the Maine Health System alone, we have over 211 kids in FY20, the state's FY20, that were waiting more than 48 hours. So clearly there is a need to understand the basis of the problem and then to develop the short-term solutions as well as the long-term solutions to addressing it. Thank you.
Okay, thank you. Any other questions from the committee? Any other information to help figure out the next step? I have a question. Oh, yes, Representative Lemlin.
I have a question and a concern. Reviewing this bill, I don't see how this bill is going to solve the problem that I'm hearing. But my question is to Dr. Landry. Do you think your plan that you have in place now will solve the issue at hand quickly enough? And if not, do you have a secondary plan that could move things along and solve this issue? I just don't see how getting more data is going to solve the issue. We already know there's an issue. So what I feel is we need to expedite things, and I'm wondering if you have the tools in place to do that.
Representative Lemon, thank you very much for your comment, and I agree with the premise of your question. Regarding specifically the implementation of the plan, what I would say is, if you had asked me that question some months ago, I don't think the answer would have been the same. But given the recent influx largely of federal dollars through the Mental Health Block Grant and through some other CRSA, the Comprehensive Appropriations Act, and the anticipated funding that we will receive via ARPA, the American Rescue Plan, I believe that we have significantly now more resources than we've had recently, and those resources now are going to be put into place as part of our strategic plan to move those pieces forward. I'll give you one example, if I may. Last year, we were fortunate to receive some Fund for Healthy Maine dollars to implement a pilot project in Aroostook County around primarily aftercare for children who have experienced a stay of any amount of time in the emergency department. The intent was to provide some intensive help to those families and those youth to help them move from the emergency department more quickly, and at the same time to help provide the services, connections, and support so that they don't have to go back into the emergency department for a subsequent recurrent event. We've only been able to put that in place for the last approximately 5 months because of the timing of the fiscal year, contracting, et cetera, during COVID and some of the other challenges. But what I can tell you is the initial results of that as a short-term solution have been incredibly positive. With CRSA funding, we are now going to extend that to 2 additional counties in the state. And with anticipated additional either CRSA or ARPA funding, we're hoping that we can extend that statewide. That's a tangible piece of short-term that we believe are going to create some very positive impacts. Will it completely eliminate the challenge? Probably not. I don't know of any state with any amount of, with all resources are going to eliminate every single stay of a child in an emergency department. Some of the youth that go to an emergency department need and are certified as hospital level of care, and that's part of the data I believe you received from some others on this bill. If they're waiting for a bed in the hospital, no amount of community services are necessarily going to help that at that point, of course. Now, hopefully, with more community services in the future, longer term, we can prevent that youth from having to go to the emergency department. But I simply use that as one example of sometimes the differences of children who are waiting. I'm not going to sit here and say that when we implement our plan fully, we're going to be able to eliminate 100% of all of these stays in an emergency department. That's probably unrealistic. Do I believe we're going to be able to significantly reduce it? Yes. And do I believe that some of the even short-term efforts that we're planning to put in place with largely federal dollars can reduce it? Absolutely. And I think the Aroostook County pilot is pointing us in that direction.
Representative Javner?
Thank you, Chair Claxton. Appreciate that. Senator Landry, in the report, you stated that you hired Dr. Carmack as your on-site medical director. I am very interested in you expanding on what you see her role as moving forward and how this would affect even what this bill is attempting to address.
Thanks for that question. It's one of the things that was one of our 13 identified strategies back in the summer of 2019. It was the first one that we completed by hiring Dr. Adrian Carmack. Dr. Carmack is a pediatrician based in the Bangor area, has a number of years of experience here in the state of Maine and elsewhere. We would be happy to provide you with our contract with Dr. or redacted, obviously appropriately for privacy information, but be happy to provide you with the list of all of her duties. She has a number of duties that include individual consultation with our staff, both on children's behavioral health and child welfare. She has responsibility for some of our oversight around psychotropic medication management for particularly children that are in care. She also has been instrumental in the past year, and she started at the beginning of March of 2020. So she started at a pretty auspicious time. She has been instrumental in our assistance in responding to the pandemic and keeping our staff safe, children in care safe, our resource parents safe, et cetera. And that's been a big piece of what she has done for the past year. Specifically related to this challenge, Dr. Carmack is brought in virtually every single one of the cases as we are working in partnership with hospitals in most cases to assist children and youth to move to an appropriate placement. She is brought in, she helps to navigate and to translate for us between the medical profession and what they're looking at and from a children's behavioral health and placement perspective. She has, even during the pandemic, she has gone out to the hospitals to meet in person when it was safe to do so in order to brainstorm some potential solutions there. And I anticipate that she'll continue to play that active role as we move forward as one of the parts of her duties. So she's been an incredible asset for us to have on board. We're delighted to have her there. And I think it's a good example of some of the short-term as well as long-term impacts as we move through completion of our 13 strategies.
Thank you, Chair. If I may have a follow-up.
Please.
Thank you. Dr. Landry, you mentioned expanding, the Aroostook County pilot program to 2 other counties immediately. Do we know which counties those will be?
Yes, we do. And I'm going to give a moment for one of my colleagues to make sure I share the exact correct counties. So if you give a moment for us, I'll be happy to share that with you. So hopefully I'll get that
Thank you.
confirmation here shortly. But yes, I can tell you the two that we've immediately committed to, as well as I indicated, with the most recent announcement of some CURSA funds that are available to us, we are hoping, and I don't want to commit yet, but we're hoping that there'll be enough of those dollars for us to potentially expand it statewide. And I do want to point out, we'll be evaluating that very carefully. It's not good enough just to put it in place. We want to see exactly what are the results. Did those youth that we impact have a recurrent stay in an ED? Did they move out of the ED more quickly? Did we reduce the number of children that are reporting to the ED for a crisis episode? Again, we can't control for everything. It's not just one piece that we're doing. We're doing multiple pieces. But if nothing else, we do believe we'll be able to control for some of those pieces and provide accurate data on which strategies are getting the results that we want for Maine children and families.
Thank you.
Representative Meyer.
Thank you, Mr. Chair. Intelligent policy in the short and long term is based on accurate data. And this sort of dissonance between what the hospitals are experiencing in the real world and what the department is telling us is happening is confusing at best. And so I wonder if the sponsor would like to weigh in on that aspect of the data and what else this bill is bringing to the fore here.
Thank you, Representative Myers. This committee is amazingly fair in hearing from everybody, and I appreciate that. And I'd just like to remind you that this bill came to the committee last session, was unanimously supported. It's been modified as we do as we keep working on things. But Dr. Tweed and I met with Dr. Landry and staff last session and talked specifically about this data piece and the need for it to be aggregated so that it was anonymous. Nobody has ever wanted to violate confidentiality. So I just want to be clear about that. My middle name is confidentiality. I worked as a social worker, clinical counselor for my whole career. I would irritate people because I was so focused on confidentiality. So I just want to say that. So I don't know why the change. Also, I think that the committee is, as the committee of oversight, has a responsibility, as this committee does so well at listening to everything. But you need to listen to the people who are on the ground and are seeing these kids in the hospitals. One of my constituents was a peer support person in one of the emergency rooms, and not revealing any specifics or being lacking in confidentiality. We work together on behavioral health issues. She is as an advocate and me as a legislator. And she was in tears about the situation the kids are in. And that's one hospital. You're hearing from the hospital representatives that this is a massive problem. It's a problem that needs, I've heard it well said, short term. Yes, we have a great long-term plan. I'm thrilled at the direction DHHS is going. But we're not there yet. We have a short-term need that's affecting kids and families and communities and hospitals and all of us today. The comment was made that the bill is, the implication was the bill is all about data. And I just want to correct that. There's a lot more to this bill than data. Data is important. I remember those of you who were here last session, it would come up over and over and over that we needed data. And the response would be, well, we have the data, but we couldn't, but how did we get access to it? So that's some of my focus on data. Let's make sure that the legislature has access to it. But the bill also talks about, as I said, the beginning was around kids stuck in emergency rooms. It's an ongoing, continual problem. We have not solved it. It's the bellwether, as someone said. Absolutely. But the rest of the bill is about digging in deep. What is going on? Some of the questions, some of the information Dr. Tweed talked about. That's where data comes in. Let's know. Let's not guess. And let's figure out what interventions need to happen now and who's going to do them. And that's many partners. So I would ask you to look at the big picture of the bill, look at the big picture of the problem, and listen to the people who are dealing with it every day. Thank you.
Thank you. Representative Dr. Landry, did you have some comments?
I just wanted to answer the question, and my apologies, Representative Javner. The two additional locations are multiple counties because we're using a DHHS district approach. So the two additional counties that we have already committed to expand the crisis aftercare pilot to is what we call District 6, which would be based in Bangor, but serving Penobscot and Piscataquis counties. And the other district is District 3, based primarily there in Androscoggin County and Lewiston, but also serving Franklin and Oxford County or counties. So those are the ones. As I indicated, my hope is that we will, using federal funds, be able to expand the pilot statewide. And once we have that information, we'll be happy to share it with you. And thank you again for the opportunity to share.
Thank you for that data. Representative Lemelin?
I put my hand down. I'm going to ask my question in a moment, if you don't mind, Senator.
Sure. Representative Madigan?
Thank you. I just want to acknowledge the all the input people have had about this. And I commend the department for their putting together a plan, which is the first thing I've seen in a long time. But I also want to agree with Dr. Landry that the system was dismantled. And that means that having a long-term plan is good, but that does nothing to solve the fact that right now, while we're ramping up with that plan, that children wind up in the emergency room waiting, and that's children and family suffering. That's also much to, I'm going to give credit to the hospitals and ER staff for working under terrible circumstances and being bereft at being able to offer anything that is helpful to families in that situation. Most, having been a crisis worker and worked in an ER, and had to help hospitalized children at times for psychiatric reasons, I know that a good outcome is when you can connect people in crisis with the services they desperately need. And that's not happening now. And it's also the services they need in the community are not as available. And I know we're working all really hard on it, but I think getting data and finding out what will help until everything is ramped up is helpful. I thank you, Dr. Landry, for putting that kind of short-term aftercare program in Aroostook County, and there needs to be more of that. And I think we need to understand, as a social worker, a systems approach, which, we can make a plan to address this long-term thing, but we're also going to have to do something that's working right now. And there's really no way around that. There really isn't, because that's what happens when you dismantle a system, is that you're left with acute problems and long-term problems. And so the plan is a solution, for a long-term kind of problem, but we also have an acute problem right here, right now. And it's really critical to remember that acute problem is, for every child that winds up staying for days, weeks in an emergency room, that's a traumatic situation for that child and that family.
Thank you. Representative Perry?
Thank you. This is really tough. First of all, I am just so impressed with the work that Mr. Landry is doing for the children in this state. And unfortunately, I think that this becomes a fact that the committee really has sort of focused on this in many different areas on this. And I look at this as being a focal point where the committee can actually look at so that we can have a discussion about how the whole system is working. It is wonderful to get a whole lot of information all at once, and we always focus in on something. But I think looking at the steam in the pressure cooker gives us an understanding and the ability to talk about the rest of the system to see the kind of progress that we're making. And I'm thinking this mainly as a legislator, because we do have oversight, to have that discussion because we're getting that kind of a focused report that puts that into our limelight. And first of all, thank you for all the work you're doing, Mr. Landry.
So if I might, I'd like to offer an observation just for conversation. One is I think I've identified for me 4 specific issues to be addressed. One is we need to work out a system of coming up with reliable, predictable, universally acceptable data out of the emergency room length of stay. That seems to me to be the most specific of the asks out of this request in this conversation, to be able to get the hospitals and the department together to try and come up with some way so that we can reliably collect and then share in whatever format works best that data. So that seems like one thing. The second to me seems that we then need to make arrangements to regularly follow up on that data. Whether that's 3 months, 6 months, a year, I'm open to suggestions, but it seems like there's a specific responsibility falls to this committee to provide oversight of what's been identified as a significant issue. And if we can do that, then we will be contributing to the solutions. The third piece to me is some ongoing work on short-term solutions to the problems we've already identified. And then the fourth piece is long-term plans to identify the issues identified over the range of care for these kids. So those to me feel like the 4 things. Cleanup was the term in IT, the data related to hospital stays, and figure out some way to share that as we can, and with the goal being having it as visible as it is on the website that OCFS has put up and continues to improve, which is impressive. The second would be to provide some regular oversight by this committee around that specific data point, and from there to be able to ask questions about how to improve it. The third would be to have a full understanding of what the short-term plans are. And the fourth would be a better understanding of the long-term plans. My sense is that the latter 2 have received lots of attention in the department and are in multiple ways underway. But I wanted to hear from Dr. Landry about his sense both of the short-term plan or those 4 points. Before we do that and give you a chance to answer, Dr. Landry, can I go to Representative Lemelin for your question?
Thank you, Senator Claxton. As of right now, I am odd not to pass on this. And the reason for this is because reviewing the bill, Dr. Landry in his report that I just read has short-term and an immediate plan and also a long-term plan. This bill is providing more data. However, it does not provide any short-term answers. I would prefer amending this bill to have Dr. Landry give us a report back, even if it's every 6 months, on the progress of the current plan he has in place. I think the plan he has in place will work. So that's where I stand as of now.
Thank you for sharing that. Dr. Landry, your thoughts at this point that you can share?
Thank you. I'm sorry.
Go ahead.
Thank you. Thank you, Senator. If I remember right, you really were asking about 4 points there. Where are we on short-term development of, short-term plan development, long-term plan development? I believe you had a question around data and data consistency. And forgive me, I don't recall the fourth item that you mentioned.
The second was to follow up that data on the data
Follow up on that
consistency
data.
related
Yep.
to emergency room stays. That seems
Yep.
like one of our jobs.
Thank you. And so one of the things that I've tried to indicate is, and one thing that I will acknowledge is that when you throw out a term, or when anyone refers to a term as children or youth waiting in an ED, like lots of things, you can get lots of different interpretations about what that may mean. I believe we have tried to be clear that when we report the data, we are looking and reporting data on children who are waiting that is reported to us by hospitals more than 48 hours, and those that are wait for a behavioral health need and they no longer meet hospital level of care, and they're waiting for a placement either in a residential setting or back home with community-based supports. Now, others could take that same question and say, well, we're also going to count the ones that meet hospital level of care, but they're waiting for an inpatient bed somewhere within our own hospital. Since we don't have really impact in the ability of the hospital to free up their own beds, we're not necessarily reporting that in our numbers. And so that may be sometimes where you see some data disconvergence. And so I just wanted to point that out. We are certainly willing to work with the hospitals outside of this bill to ensure, to the extent that they can, that we're using the same definition and that we're collecting the data as long as they're willing to do that. That's something that we do on an ongoing basis anyway. We're happy to continue that work and commit to doing that and can report back to the committee on the success of that. I'm also more than happy to continue to report to the committee, as we did in response to 118, on annualized numbers that we believe will not have any impact on potential confidentiality disclosure. Again, we do not intend to put this on our monthly reporting dashboard because of our concerns about that on a monthly basis. But I am more than happy to commit in our future annual reports, which we have shown our ability to do every single year, to include that information. Again, I think that's a reasonable balance between protecting confidentiality but sharing that information with you. So that's a little bit about data. Let me talk, and I think where we all want to get to is short-term and long-term solutions to not just this data point and others. And that is where I believe we are absolutely on the right track. Regardless of how anyone feels about CRSA and ARPA and the other pieces, I am more than happy to utilize Maine taxpayers' federal tax dollars that are coming back to the state of Maine to benefit Maine children and families in this area. I'm more than happy to do that, and that's what we're going to do. And I do believe that some of the other pieces that we have in place, including the legislature's recently passed budget to continue children's behavioral health general fund dollars, will also enable us to continue to move the strategies forward. So I think we're in an opportune time period. Fortunately, we've done the work. We have the plan. We've initiated some action on the plan. Now my hope is with the federal dollars, we can accelerate some of those. But I also want to caution the committee, this problem will not be resolved in the next month or two. It's going to take time. It took 10 years to get us where we are. We've only been a year and a half into the resolution. It's going to take some time. But we look forward to moving those needles and pushing those pieces forward. With that, thank you again for the opportunity and the indulgence.
Dr. Tweed, you've had your hand up and down a couple different times and been patient listening in on this. So I'd want to make sure you have a chance to speak your mind.
Well, actually, thanks for waiting, because I was appreciative of hearing Dr. Landry's comments. About the data, Um, yeah, I think we need to work together on the data to make sure. I mean, we have a lot of kids at the hospital system I work at that are assessed hospital level of care, very aggressive. They don't get in the hospital after a certain number of days. They have to go home. You know, and they are the most aggressive kids in the system because they're the ones that the hospitals had the most reluctance to hear about. And actually, this gets too much in the weeds and is more for some other, you know, kind of working committee, because I'm not sure if the department's getting information from its mobile crisis providers. Because if it actually, may I ask, Todd, is that where your information is coming from at this point, the mobile crisis?
The information comes from multiple sources. The mobile crisis providers are one, but we get direct information from hospitals and other entities as well.
Okay. Well, and so first of all, to strongly agree with Dr. Landry, I think an annualized report makes a lot of sense. You know, addresses his concerns about confidentiality, and I hope we can all work together. You know, including those of us who work in the ED. I'm in the ED a lot. You know, to make a solid, reliable data collection system.
Okay. Thank you. Yes, Representative Perry.
Actually, I want to apologize to Dr. Landry. I had a brain freeze when I was addressing him before, so please accept my apologies.
Yeah, that won't be the first time that happened in any of these hearings. So for all of us, so that's okay. I don't hear a lot of move to a specific resolution. Then I'll bring up a possibility. What about a resolve that includes a report in January on efforts to make the ED data consistent and useful to the department and something that we can provide some oversight to? And then on an annual basis after that, as part of the annual report, as well as ongoing reports on short and long-term efforts to resolve or address these issues. I put that out there for consideration. Yes, Representative Javner.
Thank you very much, Chair. I am very amenable to that. I am so appreciative of all the conversations that have gone on today concerning this issue. I think it's been very, very positive. And before we would make a motion, Senator Claxton, I would ask that you allow us to have the opportunity to have a corner caucus, please.
That would be certainly all right. And I do need to reference the fact that I am building off of Representative Lemel's suggestion for a 6-month report back and just made it January while we're in session. So we can work around that. Any other comments or thoughts before we break for, yes, Representative Meyer.
Yes, thank you, Mr. Chair. I would ask that the Democrats as well caucus.
Okay, so we can go to our caucus rooms and we'll try and be back here 15 minutes. 37, 10:37. Okay, thank you very much. We will be back.
comments from the Oxford facility. Goes without.
We're gradually reassembling, and we're a little later than we had planned, but that's typical of corner caucuses. Looks like everybody's back with us. And so out of our caucus came a series of questions and consideration eventually when we get some answers, or at least put them on the table, about possibly tabling it for additional work. So I'm not sure what's come out of your caucus, but we did have some questions and a direction, and would be interested to hear what comes next. So I just wanted to flag that tabling as a possibility. Okay. So if Director Dr. Landry, are you there?
Hi, good morning. I'm here.
It's still morning, yes. So we came up with a couple of questions out of our caucus that we'd like to at least put up there and see what the response is. How, if the question first is about how the breadth of the stakeholder involvement in the development of the short-term strategy and a long-term strategy, and specifically, were players like education and providers and corrections involved? Those kinds of folks outside of what would typically be the OCFS world.
Yes, and in fact, we'd be happy to get you the full list of all of those that participated in the work groups and the multiple back then in-person sessions that we were able to do in 2019. But yes, it included all of those individuals, so multi-departmental, but more importantly, I think it was a broad group of stakeholders, including some that are on that you've heard from today. But we have representation from all of those groups, and including families and youth members as well. So yes, they were there. So corrections was there from the JJ perspective, of course. We had folks from the hospitals and hospital associations that were there. Provider associations were there. A significant number of providers themselves were there, as well as representatives from the Department of Education, and I believe the Department of Labor as well.
Okay, so I think that's a list that we would all like to review in anticipation of voting on it. And then what is your plan for ongoing follow-up of the strategic plans, the strategy itself, not the specific elements of it, but how often do you reassess the plan, or how does that go? How does that happen?
Well, to a certain degree, it happens on an ongoing basis, which is the purpose of our annual report that we put out to the public and that you all, of course, have seen a copy of. And so it's a report, and you'll probably notice in that report how we have talked about some things that we elevated some of our, strategies to short term. We moved others down to longer term, based on that ongoing evaluation and needs of which ones we can move forward. I anticipate that will continue. I would anticipate once we are further down the road, I'm not going to put a specific date on it, but I would say I think it's reasonable for us to potentially do a full reassessment of the plan, including that kind of stakeholder involvement, et cetera, at a 4-year mark. That would be in 2023. That would enable us to give plenty of time, I believe, to see what impacts these 13 strategies have done, which ones we need to modify, change, or wholesale, evolve. But I do want to make sure everyone knows that this does not mean we're not looking at it on a continual, ongoing basis. And I think our report demonstrated that.
And that would allow you to provide some informal follow-up or feedback as we went along year by year, say?
Yeah, certainly we're always taking in all of those different types of informal and formal feedback. So we're looking at all the data, most of which we have published online. We're certainly taking into account the the solicited and unsolicited feedback from from providers, from provider associations, and others. And we're adjusting as we go forward based on available resources. And using the best example currently, the federal resources are having us to adjust a little bit. And I'll provide one other example of that. When it comes to federal grants, we're very fortunate that last year, for the first time in many years, Children's Behavioral Health was allowed to apply for a large federal system of care grant. And we received that grant last year, and we began to implement it last year. That's an $8 million 4-year grant that we have provided information to this committee on previously. A different grant that we have applied for has to do with the use of mentors for youth with substance use disorders. Now, I'm going to be the first one to tell you that you're not going to see that one on our 13 strategies. But there was an opportunity to potentially use federal dollars. We heard from our stakeholders that this could be a good addition to our plans. And so we decided to take advantage of the possibility of those federal dollars, and we have written for that grant. We'll see if we receive it or not. But those are the examples of how we have to be constantly adapting and modifying the plan based on data, based on formal and informal feedback, and based on resource availability.
And 2 more questions, and then I'll go to Representative Javner. One real specific, I heard you commit to being willing to work with the hospital systems to come up with some sort of standardized, reliable data that would allow you and us to, over time, to track how we're doing with the specifics of the kids in the ED issue. So some standard definitions. And so would you be okay with a June 1 interim early progress report or update and a January 15th follow-up? Whoops, you're still on mute, sir. You're still on mute.
My apologies. I'd like a little bit more time than that. I will tell you, during the course of this call this morning, we received a outreach from the Maine Hospital Association to assist us potentially with that effort around some common definitions, et cetera. I only asked for a little bit more time because, as you know, we're not only in the middle of a legislative session, but our big priority right now as a department is accessing and implementing federal dollars through the relief acts, both CRSA and ARPA. So ideally, I'd like a little bit more time, but if we could do something in July with a interim report back to the committee and then the report in January, that's something I think we can make happen.
Okay, so and then the last question I had was about what's the interdigitation of your planning process with the Children's Cabinet?
You want to use that word one more time for me?
How is your work on planning tied to the Children's Cabinet?
Yeah, some pieces of our plans interlink with the Children's Cabinet goals and priorities regarding older youth. It's important, I think, to note that as it relates to the Children's Cabinet, of course, sets its priorities and projects around those pieces that clearly overlap multiple departments, and not just 1 or 2, but usually 3, 4, even all 5 of them. So there are some components that you'll see embedded as an overlay with the Children's Cabinet. There are others that are very clearly solely within the realm of OCFS. As it relates to this piece in particular, I think this is solely within the realm of OCFS, and we've had discussions with some of the folks that are also in the Children's Cabinet to confirm that. But there are other pieces that I think are broader, particularly some of the pieces as it relates to the overlay between education, OCFS, and corrections around some of the challenges with youth with juvenile justice issues or challenges. And so there is some overlay, but it's not 100% overlay. And again, I think if Anna was here and in my role currently with the Children's Cabinet, I would say that there's also a clear recognition that the Children's Cabinet really convenes. It really brings departments together to work on some areas of joint effort, but it is still in the departments where that work has to be done because that's where the staffing is and that's where the statutory responsibilities are.
And I totally understand that. And in terms of operations, I also know that access to political capital may come from broader participation in other groups. So that's why I was asking about the Children's Cabinet. So those are the questions that I wanted to ask. I'll refer to Representative Javner now. Thank you, Dr. Landry.
Thank you, Senator Claxton. Just real briefly, Dr. Landry, in the reports, it states that the next update for your strategies is going to be April of 2021, which is obviously this month, but do you guys have a date specifically where you're hoping to update those?
We don't have a specific date on that. I know that we're planning on doing the major reports on an annualized basis, similar to the one that you have received. But I don't have a specific date for you. Again, we continue to try to be as flexible as possible, largely right now focus on those federal dollars and plans and documents and amendments that we have to do in order to access those dollars. And that's really our big priority right now, both in children's behavioral health, but I would also add in childcare as well.
Great, thank you.
Are there any other questions, comments that people would like to make before we move to whatever the next step is? Senator Moore.
Thank you, Senator Claxton. I guess the only comment that I would like to make is, I know we're looking at possibly a resolve and some conversation around that. I think one of the things that I'm hearing too is that we really do want to make sure that we include the provider community to work with the department, in working on the short-term goals and the long-term goals, because again, as somebody else has said, those are our feet on the ground. So I think we want to keep that in the back of our minds to ask the department to work with our provider community. I know, Dr. Landry, you mentioned that they were part of the stakeholders group, and so I would encourage that continued conversation as we work towards these short-term and long-term goals.
And if I may, just in a quick response to that, I do want to point out, and my thanks to the provider community, including many of those you've heard from today that have been very involved with us in the past year on our implementation of Family First. And our implementation, as you know, on Family First has a major overlay between child welfare and children's behavioral health, and there's a significant amount of linkage there. So providers have been incredibly helpful to us on developing those plans, implementing those plans, now as we move into that stage, as well as providing valuable feedback. So we're committed to doing that, but now that work and that is not really on a large scale plan development perspective. It's really much more about now individual strategy implementation that we're really focused on.
Okay. So I think there's still some pieces to be sorted out. Senator Moore mentioned a resolve. I'm not wedded to that idea over a bill. I just want to make sure we get to accomplish what we as a committee want to accomplish. So I think there's some more work to be done. Based on that, let me go back to Representative Lemmel in a minute. If we got a preliminary report back mid-July to the committee, would that be a first step, and then mid-January for a more formal response in terms of standardizing the data?
Yes.
Okay, good. Yes, Representative Meyer.
Thank you, Mr. Chair. I would move to table this bill.
Second.
Tabled and seconded. And I guess we should do this formally and ask Ms. Withy to collect the votes, if you would.
Representative Zager. Representative Zager is absent. Representative Lemlin.
Yes.
Representative Lemlin, yes. Representative Stover.
Yes.
Representative Stover, yes. Senator Baldacci. Senator Baldacci is absent. Representative Perry,
Yes.
Representative Perry, yes. Representative Griffin,
Yes.
Representative Griffin, yes. Representative Connor,
Yes.
Representative Connor, yes. Representative Craven,
Yes.
Representative Craven, yes. Representative Madigan,
Yes.
Representative Madigan, yes. Representative Javner,
Yes.
Representative Javner, yes. Senator Moore,
Yes.
Senator Moore, yes. Representative Meyer,
Yes.
Representative Meyer, yes. Senator Claxton,
Yes.
Senator Claxton, yes. That's 11 yes, 2 absent.
Okay, in terms of things we'd like to get from or have available the next time we sit down, are there specific requests of Anna beyond the list that Dr. Landry is going to provide of the people who were involved in the development, the multi-stakeholder group that were involved in the development of strategic plans? We'd like to see that list of participants for that. Are there other pieces of information specifically? And then I would invite Representative McCray to work with Anna. And I will share some of my notes from the meeting for whatever value that has. And we'll see if you all want to go down the build or the resolve route. And we'll come back and consider this at a future work session.
Thank you.
I will thank everybody for contributing in the way they have. This is an impressive use of committee time and energy, and I appreciate the department's participation, and I appreciate the participation of folks in the provider community. I think we're going to end up with some progress has been made already. I'm hoping for some more progress. So thank you all for sitting through what's been a important conversation. So, yes, Anna, Representative Broom. Yes, Anna.
Yeah, that'll never happen. There's lots of reasons for that. I just want to clarify who I'm working with here. You did mention Representative McCrate, but are you also asking me to work with the department? What I'm not sure. Are you asking me for drafting assistance? Is that what you're asking me to do?
I pretty much, yeah. We're redrafting.
Okay, and is it okay if I work with the department, or would you rather I just work with the sponsor?
I'm afraid I assumed that, yes.
Yeah, we're always going to ask that one. Okay, thank you.
Okay. Yes, the department needs to be actively involved in any of these conversations. All right. So let's take a 4-minute break so you can stand up, turn around. 4 minutes. That makes it 11:10, and we'll get to our public hearing portion of this. As we get ready to reconvene, I'm going to step away and defer to Chairwoman Meyer while I sort out where I'm supposed to be in terms of testimony. So we're going to start with Representative Gramlich's bill, and then there'll be several folks afterwards, and I'll leave it to Carrie Withy to share that information with Representative Meyer about the order. But we're going to start with Representative Gramlich's bill 496.
Thank you, Senator. Thank you, Senator Claxton. Yes, so we would welcome the bill's sponsor, Representative Gramlich, to unmute herself and present an introduction to LD 496, an act to clear waiting lists for and ensure timely access to mental health services for Maine children. Welcome, Representative Gramlich.
Thank you, Representative Meyer. Good to see you again. You all have had a pretty long morning already, and we're going to jump right back into it with a little bit more of the same. I'll miss Senator Claxton, but I know he'll get caught up. So let me just cue myself up here for you folks. So it is still morning. So good morning again, Representative Meyer and distinguished colleagues of the Joint Standing Committee on Health and Human Services. I am Lori Gramlich, and I represent House District 13, which is the community of Old Orchard Beach. I am honored to present LD 496, an act to clear wait lists and ensure timely access to mental health services for Maine children. In Maine, we continue to face a crisis in providing for children with high needs. There are still children receiving residential services out of state, away from their families and communities, costing substantially more than what it would cost to provide for these kids right here in Maine. We are talking about children who may have severe trauma history, co-occurring substance use disorders, possible violent behaviors toward themselves or others, autism or autistic behaviors, and possible involvement with the corrections system. LD 496 aims to provide the funding mechanism to give the Department of Health and Human Services the financial resources necessary to assure that Maine children receive the mental health care they so desperately need. This bill essentially requires that the Department of Health and Human Services increase reimbursement rates by 30% for behavioral health services, specifically for children's home and community-based treatment under Section 65 of the Maine Care Manual, and for child care facilities under Section 97 of the Maine Care Manual. While an increase of 30% may sound significant, I would like to offer some perspective. The state of Maine has been wrangling with issues concerning children's behavioral health since the mid-1990s and earlier. Our history tells us that we have come to some consensus that assuring children receive appropriate, timely behavioral health care is a priority. However, unfortunately, we haven't done as good of a job putting our money where our mouth is. We have failed to adequately address the fact that we simply do not reimburse providers with an adequate rate to actually deliver the much needed behavioral health services, many of which can be perceived as preventative, that children need. In 2003, an outside expert hired by the state found that hundreds of children were still waiting longer than 6 months for in-home behavioral health services, a violation of federal Medicaid law, which generally sets a 6-month limit. In 2015, the previous administration, as I know you've discussed all morning, proposed a 10% cut to main care rates paid for key children's behavioral health services under main care sections 28 and 65. While the legislature at the time did not agree to these cuts, they also did not propose or approve any increases, but rather contracted with an outside firm to examine reimbursement rates for children's behavioral health care services, among other services. As a side note, for those who know me, I'm typically not a fan of studies, particularly when we already know the outcome. That was 6 years ago. In 2018, this committee approved a 20% rate increase for children receiving Section 65 services. These are children receiving behavioral health services through home and community-based treatment, known as HTC, which is one of the most effective ways to assure that children have the services they need and that they remain with their families in Maine. This legislation, sponsored by our colleague, Representative Madigan, passed through the House, but unfortunately did not make it out of the Senate. Over the past 10 to 15 years, we have seen increases from 50% to over 200% in nearly every single sector. Increases to health insurance costs, increases to rents and utilities, increases in technology costs. The cost of doing business continues to increase, yet we have not prioritized increasing rates for providers who deliver services to what I consider to be one of our most precious resources, our children. During the 129th legislature, this committee voted unanimously to bring children who are receiving services for out-of-state behavioral health treatment home to Maine. However, we did not appropriate the necessary funding to ensure that children can get the prevention-based behavioral health services right here in Maine. Children still remain on waiting lists for these services. Waitlists for children awaiting home and community-based treatment continues to grow. As of February of this year, 2021, we have, by some estimates, over 650 children awaiting behavioral health care services. We are not funding adequate community and in-home services for these children in our state, which increases waiting lists and puts more pressure to send children with severe needs out of state. This bill aims to help reverse that trend. Our community mental health system is in crisis, and COVID most certainly has exacerbated the need for mental health services. The needs for our children and, quite frankly, our entire behavioral health care system continue, and the workforce shortage, that is the funding largely aimed at helping this, is at crisis levels. Organizations have hundreds of unfilled jobs because they cannot pay people enough to want to be hired or continue in their chosen profession, making this an access to service issue. I urge you to consider how our spending priorities impact our children, and I know you do that. And while this bill may be perceived largely as a fiscal note, I urge you to examine this through the lens of sound, prevention-based public policy. We must act now. I thank you for your consideration, and I urge you to vote ought to pass and send this legislation to the appropriations table. I would be happy to try to answer any questions for you. Thank you all very much.
Thank you, Representative Gramlich. Questions from the committee for the bill's sponsor? Seeing none. We'll move to testimony in support of LD 496. Up first is Ms. Abigail Pierce. Welcome.
Thank you very much, Representative Gramlich, Representative Meyer, and the members of the Joint Standing Committee on Health and Human Services. My name is Abigail Pierce. I live in Bangor, and I work for Community Care, which is a nonprofit mental health agency. I am here today to testify in favor of LD 496. I'm a licensed clinical social worker and a clinical supervisor and program manager of Community Care's Home and Community-Based Treatment, our HCT program. I've worked with Community Care and in HCT services since 2007. For years, I was an HCT clinician, providing in-home support to children and their families. The children served by HCT services are high-risk, high-needs children with often aggressive and challenging behaviors. The homes in which the work is provided can be chaotic, and the environment and work can be stressful. HCT services is designed to keep families together and preserve the family unit. On a continuum of care, HCT services sits in the middle between outpatient therapy and residential and hospitalization. Without HCT services in place, some homes and families are not able to maintain their child's behaviors, and the child may require residential treatment, which is extremely costly. And open beds for placements are far and few between. Even if the rates are increased for HCT service providers, it will still be hugely cost effective for MaineCare in the state of Maine to increase the usage of HCT services in order to decrease the higher cost programs like residential programs, many of which are out of state, or inpatient hospitalizations. I have been supervising clinicians and behavioral health professionals who are bachelor's level workers that work in tandem with clinicians in the home for the last 7 years. I've continued to watch providers work long hours, face crisis with their clients on a regular basis, work nights and weekends, and juggle their schedules around day to day to meet the needs of the families they are working with. They continue to do this despite the fact that the rates have not changed for reimbursement for the work they do in over a decade. Other in-home providers providing other services have experienced rate increases by 40% in the last year and a half, while HCT provider rates have remained the same. Due to this challenge, it's difficult to employ experienced clinicians as HCT providers due to the wages they earn as a direct result of the low reimbursement rate. HCT clinicians continue to provide quality service in challenging situations year after year while struggling to be adequately compensated for their work. What we know about HCT services is that experienced seasoned clinicians would be most qualified for the positions as in-home family therapist, but we are unable to employ more experienced clinicians as a result of the low rates. What this does mean is that the families receiving HCT services are often receiving the services from a provider that might be right out of school and not experienced in the field. If the rates were able to increase, the quality of the service would also increase, which would result in better outcomes, less children on the wait list, and more success in treatment. Thank you so much for your time and consideration in moving forward with this bill. Please let me know if there's anything I can do to be helpful to answer any questions.
Thank you, Ms. Pierce, for being here today. Questions? Yes, Representative Madigan.
Thank you, Madam Chair. Thank you, Ms. Pierce, for being here today and testifying, and for giving such a comprehensive look on how this impacts children and the workers. I'm also an LCSW and have been an HCT clinician in the past. My question to you today is, can you tell me whether your program has decreased the amount of area it covers as far as referrals, and whether you think that's impacted just referrals to your area?
Thank you for that question. That's a good question. We have attempted to hire clinicians in various areas of the state. We're attempting to expand in any ways that we can to cover more of the state and take more referrals off the wait list. It has been challenging to hire clinicians in centralized locations. Bangor, for example, has been oddly challenging to hire clinicians, and I do wonder if that's due to higher rates and pay at other hospitals or different employment opportunities like that. We do cover, the Portland area. We have people in a Farmington area, Fairfield, Rockland, but we're talking like a clinician in each area. So it is challenging. There are hundreds of kids on the wait list, and each clinician can only take about 7 families due to the intense work.
I have a follow-up question. Can you speak at all about the impact of travel time in the ability for your clinicians to work with families, whether that impacts the amount of referrals they can take, or whether that impacts the amount of hours they work per week and things like that?
Yeah, that's a great question. Travel time is definitely, it can be a barrier. I do think with the increased rate, we would be able to provide better compensation for more indirect time for clinicians to travel to outerlying areas. I do frequently receive requests for children to be picked up from the wait list that are high needs, and nobody is providing services in the area in which the children live. And so that is a huge barrier. I do think if the rates increase, it would be easier to reach some of those families. The clinicians may have smaller caseloads, but be able to reach the kids that are really at high risk in outerlying areas.
Thank you very much for being here today.
Thank you.
Any other questions from the committee for Ms. Bickford? Oh, I'm sorry, for Ms. Pierce. Seeing none, thank you for being here today. Up next is Carrie Bickford. Welcome.
Unmute. Okay, so now this committee knows how bad I am at electronics. Good, it is almost, no, still good morning. So good morning, Senator Claxton, Representative Meyer, and distinguished members of the Health and Human Services Committee. My name is Carrie Bickford, and I am a former legislator and the lobbyist for Pathways of Maine. Pathways is the largest provider of home and community-based treatment in the state of Maine, and we have 9 locations around the state. And I thank Representative Gramlich for bringing this legislation forward and identifying the costly and traumatic issue that our children whose need for mental health services has escalated to a crisis across the entire state of Maine. And I have talked to many of you, and I'm not going to read you the entire testimony. I really want to hit some key points because I know my time is limited. I feel like I'm treading water, but actually I decided that that's not even the best analogy. I feel like we as providers feel like we're in quicksand, and we just can't seem to bridge the overlying issue here. We have wait lists of over 500 children in the state of Maine. These kids are, by law, supposed to be getting these services by federal statute, Medicaid statute. And I don't know why that doesn't raise eyebrows, but it just doesn't seem to, because it's been almost 20 years that this problem's been going on. And I do have a timeline on my testimony that you can please read. I mean, minimum wage has gone up more than 140% since these rates were increased. Health insurance costs have risen more than 200%. Representative Gramlich stated many other things. I wanted to just quickly point out that the pilot programs that the department had spoken about earlier to deal with this very issue, this is from my state director. They're paying a one-term bump payment for providers that are using an approved evidence-based practice model, but their goal there is to increase the use of evidence-based practice models, which are costly. It won't address the long-term issue of us being able to recruit and retain staff long-term. You can implement all the pilots you want, but unless you fix the foundational problem of our rates not being high enough to support recruitment and retention, then you're throwing money into a sinking ship. I couldn't agree with that statement more. I look at this whole, everything as a quilt. I thought about this at 2 a.m. And all of the pieces of the quilt are your bills in, the correctional facilities, the ER bill that we just heard in the work session, this bill, the out-of-state kids, homeless shelters. They're all pieces of that quilt. And the common thread that holds them together are the rates. And we can talk about,
Carrie.
Excuse me?
30 seconds.
Okay, so we can talk about that all we want, and we can talk about all these studies and all these, data collection and all of that. But I urge this committee to really look at the rates, please, because they need to go up, and we won't get this problem fixed until that happens. Thank you.
Thank you. Questions? Yes, Ann Perry.
You mentioned your testimony. I can't find it. Did you submit the testimony?
Yes, I did yesterday.
Okay, I can't.
Mary Ann's shaking her head. Yes, you have it. Okay.
Okay, I'm probably looking at the wrong bill.
LD 496. But it's actually the same almost exact testimony for LD 118 because it's the same problem.
And Representative Perry, you're on mute. Did you have an additional comment to make or question?
Oops.
Thank you. Okay. I was looking under the wrong bill. This is a good day for me.
Thank you, Representative Perry. Yes, Representative Madigan.
Thank you, Madam Chair. Thanks for being here today, Ms. Bickford. I guess my question is the same I asked of Ms. Pierce. Can you tell me, you represent Pathways, you're here speaking for them today, whether the problem with rates has led to Pathways serving less areas, or whether they've had to reduce the scope of the area of service?
Absolutely. Travel time, we just can't send our clinicians out to these rural areas because of the cost. And so we have to focus on, where we have our locations and the radius around those. And so the rural areas are going without. And that's another point to make about the rural areas, is that the data isn't there because they're not reporting, because there's no services. So I wish that we had the numbers of how many of those families are actually in those areas. And Mallory may be able to speak to that, but I know, and actually, we do fee for service, which means that you don't get paid unless you go to the house. So you could travel all the way out to Timbuktu, find out that your client has a sore throat or something, and you can't go in their home. You don't get paid. Who absorbs that cost? So those are the kind of things that come into play. And it has definitely impacted Pathways, for sure.
And a follow-up with that, do you think that just that those folks in the rural areas or areas that are underserved or unserved are not making those referrals, so that the current kind of wait list does not reflect the true need? Is that what you're?
I think the wait list is absolutely not reflecting an accurate number, because there's so many that are unaccounted for. And so where are these kids ending up? What are we seeing? Well, we're seeing a trend right now, because you're getting bills in all departments, and not just HHS. Look in criminal justice, look in the correctional facilities, because I've been there. I've been in your seats, and I know that whole silo effect that we talk about, where our committees meet and we don't know what's going on in the other committees. And I can't say it enough that there is so much overlap right now. Add COVID to the mix, and we've just got this entire problem that it goes beyond the committee, and we have a statewide crisis. And I just feel like I don't know how to make that any more clear as to what these families are dealing with on a day-to-day basis. We do a community action group, and I have one parent who comes 4 times a year. She brings her autistic son, who is like 17 or 18. I can't imagine going for over a year without getting services, which is where she's been at. And if I could have her speak to you guys, believe me, I would. 1 hour with her, I can't imagine years waiting for services. And that's what's happening. And I don't know how to bridge that gap for legislators to realize this is a problem for every single senator and every single sitting legislator. You all have families in your districts, all of you. And they're there. Where are they going? They're going to the ERs. They're going to the correctional facilities. They're going to homeless shelters, because they're not getting the services that they need to keep them out of there. And that's what we provide. And it works. And we know it works. We have a success rate with HCT that Mallory can definitely speak to. 97% success rate with a child who's received HCT. A year after they stop receiving it, they're still in their homes. That's where we want them, and not in these other costly places.
Thank you for being here.
Thank you.
Senator Baldacci.
Thank you, Madam Chair, and good morning, Ms. Bickford. Good to see you.
Hi.
I just want to indicate, I think this committee has previously deemed the whole issue with the service providers, such as mental health workers and others, as a crisis and an acute problem. I've dealt with many families, as I said before, when we dealt with the supplemental budget, who have a very hard time finding, workers to help out. And I can't say enough about the people that do this every day. They put their heart and soul into it. And we really need to not only encourage that, but to pay them a decent wage so they can support their families while they're helping our families. So I just want to express my support. Obviously, it's $8.7 million general fund allocation. Is that correct? And then it will be matched by almost 18 million from the federal government. Is that all correct? Okay. So this would go into payroll, or how primarily into raising the wages? Is that correct? Okay. I just want to clarify. I know it should seem obvious to everyone, but I just want to make sure it's correct. So, okay. So that would be a $27 million increase in wages overall. Do you think, and I would hope that would help address some of the shortage issues?
It absolutely would. Absolutely.
Okay.
Just so this committee knows, there was a 2% decrease back in 2010, I believe. I was serving at that point in time.
Mm-hmm.
And in the 128th, that 2% came back. So we're stagnant. We're still where we were back in 2002. Think about that. Rotary phones were still being used. That's how long it's been since our rates have been increased. I mean, it just blows my mind that we're supposed to be doing this job on rates that were set in 2002.
Well, I just want to indicate that I'm fully in.
Yeah, that's why that number probably seems very high. Representative Gramlich said that, but it's not, because it's been pushed off and pushed off and pushed off. And look, I've been there. I've seen the studies, studies, resolves. That's not going to help us.
Right.
What we need is we need the funding. And if you guys put the funding into HCT, you're going to see the results. It's not going to be tomorrow or next week, but you will see the results. And those numbers in the ERs will go down. The numbers in the correctional facilities will go down, and those out-of-state kids will come back. But until we do this, it's never going to get fixed. Like Scott said, you're putting money into a sinking ship. If there's other ways to do this that don't include raising rates, it's never going to happen.
Right. No, I appreciate everything that you've been doing and that you're advocating for, because I agree that raising wages is the best way to address that whole labor shortage.
Well, and one more point, these are the people that work nights and weekends, and they're dealing with a job that is not easy. You got kids that bite and kick you and, break things.
Yeah.
And you could be working for the same wage at Walmart or Target. And that's what we're dealing with. We're dealing with the competition from, all the other minimum wage jobs that are out there. And this job, does not, the money doesn't even begin to cover what these people deserve.
Thank you.
And we can't hire. Like Scott said, recruitment and retention, those are the two things that we need to do to be effective as a provider. And, Pathways is the largest provider of HCT. And I just wanted to say one more thing. Section 28 services, which to deal with the autistic children, we were the largest provider of Section 28. And if this doesn't make the hair on your head stand straight up, we closed our doors this year. And I tell people that and they, oh, okay. Well, no, it's not okay, because where'd those kids go? They're not getting services. They're not getting the services that we provided. So where are they going? We had to close. We couldn't afford it.
Thank you, Ms. Bickford. Representative Madigan, did you have a follow-up question, or is your hand still up from? Thank you.
I appreciate the time. Thank you.
Absolutely. Thank you for being here today. Mallory Shaughnessy, welcome.
Hi, thank you. And everybody can hear me okay? Great. So good morning, Representative Meyer. I believe Senator Claxton is back. Hello, Senator Claxton. And members of the Joint Standing Committee on Health and Human Services. My name is Mallory Shaughnessy. I'm the Executive Director of the Alliance for Addiction and Mental Health Services, and I am here to speak in support of LD 496. My written testimony shares with you the multiple times, as you've been hearing, we have been before this committee over the years with increasing urgency in the last 2 years to point out the crisis that we have. I was going to walk you through some of this, and I've provided some data on these wait lists from the state's website, and as well as some of our concerns around the current rate study that's happening. But then this morning I was listening in, as you all discussed, LD 118, and it was a very robust and very good discussion. And you heard the extensive dilemma of children being stuck in our emergency departments all across our state. You heard very clearly the results of this crisis in the children's community and residential behavioral health care system that we've been highlighting and bringing to this committee for a number of years. And, you know, the bottom line is just that we're spending huge amounts of money on children who escalate into crisis without the proper services and become stuck in emergency departments across our state or sent out of state, which is not only not providing them the appropriate care they need, but is actually adversely impacting them and their families. You know, please hear this. And we're spending a lot of money and using state resources in ways that actually harm our children and their families by not providing them with the appropriate care that meets their needs in the least restrictive environment in their community. We know Director Landry and the Office of Child and Family Services are doing great work to repair the grave damages to the system of care in the past decade, and we are working with them as well in this effort. However, they have not had the resources to fully support this repair that they are working on. We do have additional dollars right now with the infusion of federal funding, and we need to use them to make some immediate fixes while these repairs are being made. We need to do an immediate stopgap measure, and this bill addresses a way to do that. So please hear the testimony today. Please read my full testimony. I'm not going to walk you through all the past years. You've already been hearing all about it. You know, just know too that this committee did pass, ought to pass out of this committee just 1 year ago, right before the pandemic hit, that this was an important and needed investment in a crisis. It went through the House and Senate on March 17th and was referred to appropriations, and then everything shut down and you all never had a chance to come back.
30 seconds, Mallory.
Yep. So on top of all of that, we've now had a year of pandemic hitting our families, hitting our children very hardly. You see the press coverage on this. We cannot wait any longer. You have got to act now, or there will be nothing left to build on as we repair this. So please pass this bill. And I'd be happy to bring more information. There's information in my testimony. I'd be happy to bring more to the work session or provide anything else you need. You just have to, you're going to hear from other folks today, but it can't wait.
Thank you, Mallory. Representative Perry, question for Ms. Shaughnessy.
Actually, I can read your testimony. I got the right no, I think what intrigued me is the actually downward spiral from 2018 to 2021. The number of children in wait and the number of days they're waiting significantly increased. And
significantly.
I just want to point that out because I think that is certainly something we need to be.
And our rural areas are being hit very hard, very hard. Those children and families are not getting the services. And, you know, as has been mentioned by everybody else, Corrections Committee is hearing all about this with juvenile justice issues. Other committees are hearing about this issue and the ways that it's impacting them. This is a statewide crisis, and the pandemic has just exacerbated it. And the thing people have to realize is the pandemic may end sort of, hopefully, at some point this year with vaccinations. The impacts on mental health and anxiety and substance use and all of this is going to be rippling through our community for years post this pandemic. This is something that we need to address now and over the next few years much more intensely than we even have, and we haven't been doing it.
Thank you, Ms. Shaughnessy. Up next in the queue is Betsy Sweet. Welcome, Betsy.
Thank you so much, and thank you to the committee, Representative Moore, Senator Claxton, members of the committee. I am Betsy Sweet, and I'm here today on behalf of the Behavioral Health Collaborative, which is 8 nonprofit community-based services organizations that provide over 75% of the mental health services in the state. And you've heard it. I don't want to repeat what other people have said, but here we are again and again. I think I've spent a lot of my last 10 years coming before some version of this committee to say the same thing, which is the rates are not adequate to provide the services that we need. And it is, as Mallory just said, it is an investment that keeps us from spending money in places where there's not best practice, which is where we don't see improvement in corrections and emergency rooms. And so this is our time. I also know, just very quickly, just one of my organizations, Sweetser, has 1,000 people on the wait list for all services, 27% up since December of 2020, just in the last 3 months. It takes 41 or 42 days for people to even get a scheduled appointment, right? So remember that these aren't just numbers. This is that mother with that autistic child or the person who's having a mental health crisis having to wait a month and a half, right? In addition, in the workforce, they have 11% of their workforce, and I know Spurwink has 15% of their workforce that is vacant. And the number of applications for these positions has gone down significantly since December of 2020. And I think Carrie Bickford mentioned, we're not competing with each other, we're competing with other sectors of the economy. So you know that it's a problem. It's also for you a Sophie's choice, because the elderly and the nursing homes and people with DD are all going to come before you with this same lament. So I've been working really hard to say, okay, how can we help? How can we possibly fix this? What can we do? And we heard from the department, or you have a letter from the department saying they already gave money to children's residential. I want to remind you of testimony that Ken Holson gave, that the money that is in there for children's residential, children's PNMI, which we are transferring to QRTP, which is great, but that doesn't even get us back to baseline. So it's not enough money to actually provide the services that we need. The other thing is that we have to wait for the rate studies. We've heard this over and over again. And if you go back to your report from the department, they are saying for Section 65 and community-based health services, we're going to wait 2 years. We can't wait 2 years. So what I want to suggest is something that's been talked about a little bit, but I want to really bring it home, which is we have an incredible opportunity here to fix this. We have federal money that is coming in that is going to be targeted directly towards child abuse prevention, towards mental health services. We can pay for extra money, for COVID money, a stipend, however you want to say, for the next 2 years.
30 seconds, Betsy.
For these workers and others, while those other studies are being done to tell us what the exact right rate is, but we could use that federal money. You could determine and direct the department and the governor to use that money in this way so that these services don't collapse and we lose our foundation. It's a very plausible thing. It's very possible. And we'd love to help you figure that out. And I will just say my last thing is to Representative Madigan's point is, yes, rural services, the travel time, the ability for people to get out, shutting down the geographic area that we serve is happening in all our services, and in these services in particular. Thank you very much.
Thank you, Ms. Sweet. Questions from the committee for Betsy Sweet? Seeing none. Our final testimony on this bill is Mr. Paul Dan. Welcome, Mr. Dan.
Thank you, Representative Meyer, Senator Claxton, Representative Gramlich, and members of the committee. My name is Paul Dan, and I'm the Executive Director of NFI North. And I'm here to kind of give you a bird's eye view of both the HCT as well as the Section 97 PNMI Children's Group Home experience. I've submitted written testimony, so I'm not going to go through all of that in detail, but I want to hit on a couple of key points because a lot of it's already been raised. First of all, it was interesting to sit in on 118 because the first thing that I thought about was systems. All of these things are interrelated and they're interconnected together. Right now, we have a very hard time within our children's residential programs. I operate in my organization 6 of them, and we've been doing it here in Maine for about 30 years. We have a very hard time attracting and maintaining a workforce to work with the very traumatized and challenging youth that needs all kinds of support. We've had in the past number of years as much as a 30% turnover rate. If you think that that does not have an impact on the way services are delivered, then you're not really understanding. The reality is that with that kind of churn, you're constantly struggling to maintain stability, make sure services are done in the highest quality possible. The other thing is that we've had vacancies within our residential programs. That means that we cannot maintain ratios that we're required to have, which means that we can't take children in, which means that children sit in emergency rooms. We also are a provider of HCT services, and we have similar issues there in terms of maintaining a workforce. So the one thing I want to say very clearly is it's about systems, and all of these things are interconnected. We haven't had rate relief since in the PNMIs, Children's Services, since 2008. Now, I've been at this a long time, and I know some of you have as well. And what I regularly hear is, well, we have a study and we're gonna, we've got a plan and we're kind of working on it. We're getting it worked out. I really do appreciate all the planning. I think that the department is working very hard to kind of rebuild from where they were. But the problem is that we're in a severe crisis right now. I presented to my board on March 29th at our last board meeting, our budget for next year. And I want to tell you, I went into that meeting with an anticipated $500,000 loss combined in those 6 programs. That's what my board said. Well, Paul,
30 seconds, Mr. Don.
what are we going to, thank you. What are we going to do here? I said, well, you've got to trust me, because either we're going to work it out. There's this bill could help us to solve that problem. Or we may have to start to close down services. Other providers have already done it. They've already begun to close down services because they can't keep it going. So I ask you very much to support this. I want to suggest a yes and approach.
Oh, sure.
So rather than a no but. So let's do both. Thank you so much. Yeah.
Thank you, Mr. Dan. Representative Madigan, question for Mr. Dan.
Thank you, Madam Chair. Thank you, Mr. Dan, for being here this morning. I believe it was Ms. Bickford testified earlier that the rate has essentially been stagnant since 2002. So I have a couple questions about that. First of all, that was 17 years ago. Did you have an electronic medical record then?
No, we didn't. And we've had to add that at a huge expense.
Right. And can you, for the work session, and I would ask for you to do this, and any other providers or representatives of providers that are here, could you provide some information about what the percentage of increase in costs are regarding health insurance or electronic medical records, just technology costs, all those kind of things that have impacted what the ability you have to be made whole by a rate, and perhaps how that's affected employee benefits. In my experience, being a former program manager, the value of benefits has increased in these past.
The cost of them
decreased.
Absolutely.
Things like educational stipends or things, all the people you have working for you have continuing education requirements they have to do to maintain licensure kind of things. So how much is that also being pushed off on the workers?
Yeah, I'd be happy to. I can just give you an example right now with our healthcare brokers. We're looking at a 6% increase in cost. Last year, it was a 9% increase. This is the cost to the agency. And by the way, we pay for most of it, but our employees have to pay for it too. So it further shrinks their amount of take-home pay. So I'll be happy to provide as much information.
Thank you very much, Mr. Dan.
Thank you.
Seeing no further hands up, thank you, Mr. Dan, for being here today.
Thank you.
I would ask the committee if there are any requests for additional information for our analyst for the work session. Seeing none, I will. Representative Madigan, your hand is up. Did you have? You're on mute.
Yeah, I just, for the work session, and if you could make sure that we know that people get the history of any court cases that impacted what the ability, the requirements the state was required to do in the provision of mental health services for children, and any subsequent rate cuts or program cuts that happened after that. That would be great.
Thank you. With that, I will close the public hearing on LD 496. And before we proceed with the rest of the public hearings for this afternoon, I just wanted to address the order of those public hearings and a few other points that I failed to address when we opened up this morning for public hearings. So the order for the rest of the afternoon is 432, 533, 783, and 888. For those testifying, please ensure that the name you're using on the Zoom webinar matches the one you're using when signing up to testify. And we would ask that in order to help our clerk manage the attendee list, you exit the webinar once you've finished your testimony and answered any questions from the committee, and watch the rest of the hearing live on YouTube. We take testimony in the following order: sponsor, any co-sponsors, and other legislators, those providing testimony in favor of the bill, then those opposing the bill, then finally any neither for nor against, but with additional information for the committee. We do run a 3-minute clock on testimony, and you'll receive a prompt when you have 30 seconds left asking you to kindly bring your testimony to a close. Public hearings are just that, for the public. The process of hearing testimony certainly engenders and encourages probing questions on the part of the committee, and all are asked to use the raised hand function in order to ask those bill-related questions. With that, I will open the public hearing on LD 432, presented to us by our very own Representative Madigan. Welcome, Representative Madigan.
Thank you, Madam Chair. And we still have 5 minutes left of morning. So good morning, Senator Claxton, Representative Meyer, and fellow members of the Health and Human Services Committee. I'm Representative Colleen Madigan, and I represent part of Oakland and part of Waterville. I'm here today to introduce LD 432, Resolve to Improve Behavioral Health Care for Children. I've been a social worker for over 25 years. In that time, I've worked with numerous children and families across the state. You don't work with kids and not work with their parents, their teachers, case managers, medical or psychiatric providers. The standard of care demands it. Many models, interventions, or evidence-based practices explicitly require it. In addition, when working with families involved in the child welfare system, multiple people are involved with the family, and family team meetings with child protective workers are critical in producing the best possible outcomes. And yet current main care rules do not allow a licensed master's level professional to bill for the time they spend coordinating care with other professionals. Despite the standard of care in providing mental health care to children, saying that this is the best practice and produces the best outcomes. Children are not islands. They live in families. They go to schools. They have pediatricians and psychiatrists, and they live in communities. 2 years ago, I was appointed to the Justice for Maine Children's Task Force. It was initiated by the Maine Chief Justice. This group brings together judges, lawyers, child protective services personnel, legislators, advocates, and providers together to identify and address systemic issues impacting child welfare and mental health issues. One of the consistent things I have heard there is the difficulty providers have in participating in collateral contacts, team meetings, etc., because they are not reimbursed for their time. One of the ironies of this is that the lawyers who work on child protective cases can bill for all the time they spend talking to people involved with the case, but the professionals actually providing the care and the interventions cannot. This impacts whether these professionals can do their work effectively. With the erosion of the value of main care rates over the years, the amount of billable hours mental health employees are required to meet every week has increased. This impacts the quality of care. I want to be clear. I do not say this to denigrate the good work these professionals do. I say this as a person who has been a therapist and a program manager. When one of the measures you are evaluated on at your job is how many billable hours you produce, you will feel pressure. You want to do well at your job, get a good evaluation, and earn a raise. The flip side of that is that to really do the job required to help the children now requires a provider to spend a lot of the hours that can't be compensated working with other critical people in the child's life. It puts providers in a terrible bind. I want to allow children and families to get the best possible care with the best possible outcomes, using the most effective treatment modalities. One of the best ways I know how to do that is to make sure that well-trained professionals are compensated in a way that allows them to do this. This bill will allow for this compensation. Thank you. I want to add a couple other things about that. We're talking about Section 65, basically outpatient level of care with children. Some of the home and family community treatments that we discussed in the previous bill, in some ways have that collateral kind of contact baked into how it's built. And I want to be really clear that I applaud the department for the good work they're doing. But the rates and the way people can bill and what they can be reimbursed for absolutely impact the quality of care children can get. And I want to tell a few stories about that. Years ago, I had a kid that I was her therapist, and she lived in an area of Waterville that had a number of child sex offenders living there. And the police often would send a note alerting neighbors in the area that a sex offender had moved into their neighborhood. This child developed a pretty serious anxiety disorder, and we did all the typical cognitive behavioral therapy things that could be done. And then I realized that there needed to be community work done with that. And it took a lot of work with one of the local police officers to kind of meet with this child and her family and some for that child's mental health. And I think the folks that are really involved, and much like other professionals, are able, it only makes sense that these professionals are allowed to be compensated.
What this bill is trying to do, it's what does additional.
Years I worked in and was the program manager for a school-based mental health program, and observation of a child in school, or talking with teachers, what things work, what things don't, and then be able to kind of as a team come up with approach that addresses those behavioral problems, particularly models that address ADHD in children, really require working with parents and teachers and other people like daycare providers.
How would you go about getting this done exactly?
Well, which this bill is talking about. To get an authorization for that, there has to be a treatment plan. And so being able to put in the treatment plan, this is how I'm going to achieve these outcomes with this child. This is the behavior going to improve. We're going to do it by this, and this. And you can certainly put down, working collaboratively with teachers or childcare providers or parents or psychiatrists to improve, behavior A, B, C, or D. And so it would have to be identified as a goal in a treatment plan, which is the standard that we follow in behavioral health care.
Okay, one last thing. Can't that be implemented in an IEP already?
This is different than an IEP. An IEP is regarding kind of what's going on at a school. As I said, I was a school-based mental health provider for a long time. Some of those children may have been a child receiving special ed services and may have had an IEP, but not every child. Not every child who necessarily can benefit from mental health care is necessarily receiving special ed services.
Okay, thank you.
Any other questions for the bill sponsor? Seeing none, we would invite Nancy Cronin to provide testimony.
Thank you very much, Senator Claxton, Representative Meyer, and distinguished members of the Joint Committee on Health and Human Services. My name is Nancy Cronin, and I'm the Executive Director of the Maine Developmental Disabilities Council. For years, I have watched children with developmental disabilities receive services through multiple parallel systems. It is not unusual for a child with disabilities to receive special education services, perhaps with educational technician support, then after school receive either Section 65 or Section 28 behavioral health professionals support. I just know the IEP would not be able to pay the BHP for the time of collateral contact. The IEP might be able to write in some time for the ed tech, but it would only be one half of the equation. That same child may also receive speech therapy at school through the educational model and then speech therapy at home through the medical model. These are just two examples of parallel services between the educational and medical system. LD 432 would allow collateral contact to be a billable service. Collateral contact would allow that ed tech to coordinate with that BHP. So for example, the child who has been learning appropriate ways to get their needs met and get the same message from all the professionals around them, as opposed to different messages that confuses the child. The speech therapist at school could talk to the speech therapist outside of school, so that same method for therapy can be delivered, maximizing the skills for that child. This really does just make sense. My only request is that this bill be amended to ensure professionals who work with children through Section 28 are also able to be reimbursed for collateral contact time. This issue is not just for children with behavioral health needs, but also children with developmental disabilities. It is extremely important that coordination of care is able to occur to maximize treatment. I appreciate the opportunity to speak with you, and I'm happy to answer any questions.
Thank you, Ms. Cronin, for being here today. Questions for Nancy Cronin? Seeing none.
Thank you.
Up next, Mallory Shaughnessy. Welcome back.
Thank you, Representative Meyer. Good afternoon, Senator Claxton, although I think we've lost him again, and Representative Meyer and members of the committee. I am Mallory Shaughnessy, resident of Westbrook and the Executive Director of the Alliance for Addiction and Mental Health Services. Thank you for the opportunity to speak on behalf of LD 432 today. Our reading of this bill or this resolve would be to expand the definition of the collateral contact to include the additional contact types that a child might need. And we wholeheartedly agree that this is the best interest of the child and the child's treatment outcomes. As you've been hearing, we live in an increasingly complex world and children interact with many settings. So the expansion makes sense. However, the resolve doesn't affect the maximum number of hours of collateral contact in a year. And we would suggest that you might want to consider that. It's currently 10 hours total of billable face-to-face collateral per year of service. And that 10 hours, if you stretch that over a year, that is not a lot for a child with complex needs. So we would just urge you to consider potentially even increasing that a little bit. But with that, we would be happy to provide any other additional information. Thank you for your support or for your opportunity, and we ask for your support.
Thank you, Ms. Shaughnessy. Questions for Mallory Shaughnessy? Seeing none, that concludes the testimony of those in the queue. So I would ask the committee if they have any requests for additional information for the work session. Yes, Representative Perry.
Just have a question, and it might be worth asking the department if they had considered using, instead of hours worked and that kind of stuff, as a bundled type of service that allows the full holistic care of the child.
Thank you. Seeing no other hands up, I will close the public hearing on 432 and open the public hearing on LD 533, an act to expand the statewide voluntary early childhood consultation program. And I am seeing that Senator Breen will be here momentarily. So I would suggest we take a 5-minute break and reconvene at 12:15.
Hello, it's me. I just called to say I love you.
Representative Madigan, you might want to mute yourself.
So we'll resume the public hearing portion of our day as we continue to play musical committees. And welcome Senator Breen to introduce LD 533. So we'll turn that over to you now, Senator.
Thank you so much, Senator Claxton. And hello to your co-chair, Representative Meyer, and to all the members of the Health and Human Services Committee. I've submitted a memo with this bill that I thought would probably be the most effective way to communicate why I put in the bill and what I'm hoping you'll do with it. For those of you who've been on the committee for a little while, you might be familiar with the early childhood mental health consultation program that we put in place as a result of the 129th legislature. The research and the work that went into this to begin with was actually overseen by the Education Committee, but with change in administrations and funding streams and that sort of thing, it wound up over here with your committee. So just to give you some background, there has been a problem in Maine, and Maine is not unique at all, with early childhood settings, kids in those settings showing up with some persistent behavioral problems that go beyond the capacity of the teacher, daycare provider, adult provider, whether that's in an educational setting or in a childcare setting. And what we learned through a lot of research several years ago is that a lot of those kids are being asked to leave those programs, not out of any malice or any bad intention, just that the needs that child presents are often more than what the provider can attend to effectively. So that situation gave rise to a bill that passed last session that set up an early childhood mental health consultation program through the Office of Child and Family Services, and you'll be hearing from them after me. And that right now, those are in pilot programs. So the pilots got started a little bit later than we had hoped due to COVID, which is totally understandable. So there were 5 that got started as a result of the legislation. And then in recent months, some new money became available and OCFS actually grew that number. So there are more pilot programs now in different parts of the state. And before all is said and done, those pilot programs need to be evaluated, and the program might need to be changed somewhat before it goes statewide. And so this bill is really a placeholder in the event that the legislation that defines the program might need to be changed after the pilot projects are done and the evaluation phase is done and the program continues on its way to roll out statewide. So what I'm hoping is that you folks will just keep the bill in your possession until next year, until 2022, when there's been more work on the pilots. Maybe the evaluation program has started. I'm not sure exactly. You'll hear more from the department about that. So my hope is that you will just keep it in your possession and we will revisit it if necessary at a later date. And it might not even be necessary. So I'll stop there and see if you, Senator Claxton, or any members of the committee have any questions.
Thank you, Senator Breen. for introducing LD 533. Are there any questions of the committee? I don't see any at this point, but thank you for being here, and I'll let you get back to your other duties.
Thank you so much.
We're joined also by Rita Furlow speaking in support of the bill. So I defer to you, Ms. Furlow.
Good afternoon, Senator Claxton, Representative Meyer, members of the Joint Standing Committee on Health and Human Services. My name is Rita Furlow, and I'm the Senior Policy Analyst at the Maine Children's Alliance. And I'm here today to provide testimony in support of LD 533. The Children's Alliance is a statewide, nonpartisan, nonprofit research and advocacy organization whose mission is to promote sound public policies to improve the lives of children, youth, and families in Maine. This is an effort that that we have worked on with Senator Breen now since, I believe it was 2014 when this effort began, and we started exploring potential solutions and also really trying to get better information and data on really what initially was us just continually hearing about these kids from many different settings, early elementary school, preschool, and childcare settings in which very young children were having some very significant behaviors that educators really didn't feel they could manage. And so after a lot of work with numerous partners and the Department of Education and the Department of Health and Human Services, really everyone through the research landed on this early childhood mental health consultation as having the best research and evidence in terms of effectiveness to try to help educators and parents learn to manage behaviors and identify what might be going on with kids very early. We think this is an excellent prevention tool, and have been very pleased with the efforts of OCFS and the work that they've already done in terms of hiring staff, creating a program, working with a very successful model that already exists in Connecticut. And so we are anxious to learn more as this program gets off the ground. But just again, this is something we and a number of partners have been working on for a number of years and are very pleased to see it moving forward. So thanks for letting me testify today. Happy to answer any questions.
Thank you for your testimony. Are there any questions of Ms. Furlow? I don't see anybody else who wants to testify in support, or anybody who wants to testify against. So I defer to Dr. Landry for neither for nor against.
Thank you, and good morning, Senator Claxton, Representative Meyer, and members of the committee. Again, for the record, I'm Todd Landry, Director of the Office of Child and Family Services within the Department of Health and Human Services, and here today to provide some information regarding LD 533. This bill, as you've heard, would provide additional funding to expand the Early Childhood Consultation Partnership, also known as ECCP. As you heard from Senator Breen, the legislature previously approved and funded an ECCP pilot with 5 sites. Since receiving this funding, OCFS has made significant progress in implementing Maine's ECCP, including hiring a project manager, collaborating with stakeholders to study and select a model, and implementing the selected model within Maine. As you heard from Ms. Furlow, the Connecticut ECCP model was selected based on the strong evidence supporting its effectiveness, and OCCF and OCFS has also procured providers for each of the 5 pilot sites and retain the services of an independent evaluator to study the effectiveness of the program in those pilot sites. Earlier this year, training for the ECCP consultants was completed, and they have been providing services for the past few months. Although ECCP has only been underway for a few months, OCFS is already receiving positive feedback from providers, including the effectiveness of training targeting the needs of early childhood staff and the particular children in their care. To quote one provider who said, quote, "I have noticed the team reacting differently and making meaning of behaviors rather than just feeling overwhelmed. There is a sense of confidence in themselves and one another that has increased." And I think this is a good example of the effectiveness of the model that embeds this expertise in early childhood educators, which means it's not only benefiting one child, but benefiting all the children in their classrooms as well as their families. Now, in order to ensure a robust sample and a comprehensive evaluation of Maine's ECCP, OCFS is planning to use federal funding from the Federal Coronavirus Response and Relief Supplemental Appropriations Act, lovingly referred to as CRSA, to expand this pilot or the pilots and evaluation to 3 additional sites. With an 8-site evaluation, OCFS believes the final evaluation will be of significant value in considering further expansion of ECCP. We understand, and as you have heard from Senator Breen, that she has requested that this bill be tabled and carried over to the next session. We support that approach in order to provide time to move the expansion efforts forward, to get more information from our ongoing evaluation so that we can make the best decisions in going forward with ECCP. So we want to make you aware of this information as you consider the proposal. Thank you again for the opportunity to be with you, and happy to answer questions that you may have.
Thank you, Dr. Landry. Are there any questions of the director? I don't see any. So I think
I'm sure I'm the last person that they want to have any questions of after this morning. So thank you all very much.
No, that was a robust discussion that was productive this morning. So that's okay. So that'll conclude the neither for nor against testimony in response to this bill, and conclude the public hearing portion of our initial consideration of 533. At this point, in respect of the request of the sponsor, we could go to a work session, and yes, Representative Craven?
Oh, go to the work session.
I'm not hearing you. I'm not hearing you.
I move
Yeah. We're having trouble with your audio. Can you turn off your video? Representative Perry?
Yes, I'd like to move that we go out of hearing and go into work session.
Second.
There's been a move and a second, a motion and a second to move to a work session. I don't think we need to poll the committee for that. We can just do a show of hands. All those in favor? Unanimous of those present. Thank you. Representative Craven, your hand was up too. We really are not hearing you. Your video feed is your audio feed.
No, I was going to make that move into work session.
Okay.
Can you hear me? Still not hear me?
We can barely hear you, but we understand that that's where you were going, so we'll stay there. So we're now in a work session. We're now in a work session. And the sponsor has requested that we table this with the eventual plan to carry it over when the how to do that is clarified. So I'd entertain, yes, Senator Moore.
I would make that motion, Senator Claxton.
To table this motion,
Yes.
table this bill.
Second.
I second it.
I see lots of seconds. So I don't think we need to do show of hands. Oh, I think we can use the show of hands technique again. I don't think we need to officially poll. All those in favor of tabling this motion with the idea that it's going to eventually be carried over, please show your hand if you're in favor. That is unanimous of those present. The work here is done on LD 533 until we get some direction on terms of how to carry over. That's not been determined yet. So thank you for being here, Senator Breen, and thank you for bringing that forward. Dr. Landry, appreciate your perspective, and we loved hearing stories of successes. So let's hope it's continued. All right, so that'll conclude the portion on LD 533, both the public hearing and the work session. Thank you for that. We'll go back into the public hearing this time for LD 783. And I see that Representative O'Neill is going to be presenting this. But I'm not seeing, while we wait for her to get into the room, why don't you, Senator Baldacci, are you just joining us? Why don't you introduce yourself?
Thank you, Mr. Chair. I've been here for a little while.
Okay,
but
well, I haven't been. Okay,
I've kept myself a potted plant, so.
Okay, all right.
Joe Baldacci from State Senate District 9, which is the city of Bangor and the town of Herman. Thank you.
I'm
Mr.
just
Chairman.
watching Labor Committee over here, and I missed that. Representative Meyer.
Thank you, Mr. Chair. Ms. Withy, do we know a status on Representative O'Neill?
I've reached out twice, and she did ask for a notification when we were close to her bill, so it might just be a few minutes.
Okay.
So one of the other bills on this morning's agenda is LD 888. So I think we'll move to consideration of that since it'll be a very short process. We've been asked by the sponsor to, well, we've been told by the sponsor that she had intended to, or he had intended to file a leave to withdraw. But because the public hearing had already been published, you can't do that. So my plan today, if it is okay with the committee, was to read the title of the bill and count that as the public hearing, unless somebody wants to comment. So the bill title is An Act to Ensure Ongoing Services for Victims of Sexual Assault and Domestic Violence. I'll offer a little bit of brief testimony in that people are felt it's no longer necessary because we've passed the biennial budget, which includes monies for sexual assault and domestic violence. So that was why LD 888 was a candidate for withdrawal, but we got to publish it early. So that will constitute my contribution to the public hearing. Has anybody got any questions that they'd like to ask? Okay, so there's nobody else. Yes, Senator Moore.
Do we need a motion to go into work session to discuss the bill?
I think that'd be a good idea.
I will make that motion.
Thank you, Senator.
Second.
I hear seconds from several people in the committee. So we're now officially in a work session on LD 888. Given what we know about the sponsor's intent, I'd entertain a motion to ought not to pass.
I'll second that.
Representative Perry, did you make that motion, ought not to pass?
Yes, I did.
And then Representative Stover seconded it before you made it, but we're good. All right. So there's been a motion ought not to pass on LD 888. Is there any discussion about that? Then we can officially move to polling of the for the votes, and we defer to Ms. Withy.
Representative Zager. Representative Zager is absent. Representative Lemlin. I think his, oh.
Yes.
Representative Lemlin, yes. Representative Stover.
Yes.
Representative Stover, yes. Senator Baldacci.
Yes.
Senator Baldacci, yes. Representative Perry.
Yes.
Representative Perry, yes. Representative Griffin.
Yes.
Representative Griffin, yes. Representative Connor. I'm sorry, I didn't catch that.
I apologize. Yes.
Representative Connor, yes. Representative Craven. Representative Craven, yes. Representative Madigan.
Yes.
Representative Madigan, yes. Representative Javner.
Yes.
Representative Javner, yes. Senator Moore.
Yes.
Senator Moore, yes. Representative Meyer.
Yes.
Representative Meyer, yes. Senator Claxton.
Yes.
Senator Claxton, yes. That's 12 yes, 1 absent.
Very good. So that brings us back to LD 783. And I'm having trouble getting to that portion where we might be able to see Representative O'Neill's testimony if it's been posted already. Because I'm trying to monitor two things at once. So does anybody have access to her testimony and maybe could read it in?
I have it, Chair, if you'd like me to read it.
Yes, Ms. Withy.
If we take a minute, I could also make a phone call as well.
Okay.
Oh, I think, never mind.
Why don't we take 4 minutes, reconvene at 12:40 and see if you've been able to find the person bringing that forward. Thank you for the offer though, Representative Connor. We may be back to you. It being 12:40, I'll defer to Chair Meyer from here. My testimony won't be needed at least until 1:15, so I'll be here.
Thank you, Senator Claxton. Ms. Withy, any contact with the bill's sponsor?
An attempt has been made to contact her and let her know. I'm just not sure if she's going to be able to join us in the next couple of minutes.
Okay. With that, we will take Representative Connor up on his offer to deliver the sponsor's testimony. Representative Connor with us? There he is. We're not able to hear you, Representative.
I apologize. I can read the submittal if you'd like me to read it.
Absolutely. So I would open the public hearing on LD 783, an act regarding the membership of the Sexual Assault Forensic Examiner Advisory Board, providing the sponsor's testimony. Kindly this afternoon is Representative John Connor. Take it away.
All right, Senator Claxton, Representative Meyer, and honorable members of the Health and Human Services Committee. I am John Connor on behalf of Maggie O'Neill, representing House District 15 in Saco. Thank you for the opportunity to come before you today to present LD 783, an act regarding the membership of the Sexual Assault Forensic Examiner Advisory Board. 1 in 5 Mainers experience sexual violence at some point in their life, according to the Maine Coalition Against Sexual Assault. When survivors seek medical care, it is critical that providers are fully equipped to provide comprehensive medical care and forensic care. A sexual assault forensic examiner, or SAFE, is a healthcare provider who has been specially trained to provide medical and forensic care for patients who have experienced sexual assault or abuse. SAFE training includes how to collect, document, and manage forensic evidence using the Maine Sex Crimes Kit. It also prepares providers to testify in court as an expert or fact witness. Examiners may be registered nurses, nurse practitioners, physician assistants, or physicians. The Sexual Assault Forensic Examiner, or SAFE program, issues recommendations to support this education and training. The SAFE Advisory Board is charged in statute with advising and assisting with the creation, growth, and substantiability of the SAFE program. The board provides guidance regarding training standards, technical assistance, and resources. LD 783 adds an additional sexual assault nurse examiner to the SAFE Advisory Board, as well as 1 representative of law enforcement. It also clarifies that 1 board member must be a representative of a sexual assault support center. And it changes the member representing the State Board of Nursing to a member representing a school of nursing. The chair of the SAFE Advisory Board, excuse me, Sherry Thornton, is here today to walk you through the proposed changes. Those changes were approved by the board's membership and brought to me by the Maine Coalition Against Sexual Assault. I would also be happy to answer any questions you have for me. Thank you for your consideration.
Thank you, Representative Connor. I will ask that Sherry Thornton unmute herself and present your testimony. Welcome.
Thank you very much. Good afternoon, Senator Claxton, Representative Meyer, and members of the Health and Human Services Committee. My name is Sherry Thornton. I'm a resident of Burnham in the County of Waldo. I am the current chair of the Sexual Assault Forensic Examiner Advisory Board. I've been a nurse for 45 years and a forensic nurse for 22. 16 of those years in forensics as the forensic program coordinator for the Kennebec Somerset Regional Collaborative, which covered all 6 hospitals campuses in Kennebec and Somerset County, as well as the Togus VA. I'm here in favor of LD 783, an act regarding the membership of the Sexual Assault Forensic Examiner Advisory Board, because representation needs to be consistent for the advisory board to act within its defined purpose. The board's purpose is to advise and assist the state in promoting and supporting the statewide creation, growth, and sustainability of sexual assault examiner programs. To accomplish this purpose, the advisory board requests the following changes to its composition. Remove the seat for the State Board of Nursing, which has never taken part in this board, and replace it with a seat for a representative from a school of nursing, preferably one with a forensic nursing program. This change is requested since continuing education is important to the forensic nursing field, as well as the ability to assist and create training sessions specific to forensic nursing. Number 2, an additional seat for a forensic nurse. There is currently 1 seat for a forensic nurse on the board. It would serve the forensic nurses in Maine to have a second voice on this board. The second voice would give the board a clear thought as to what the forensic nurses in Maine need in education and programming to sustain their specialty in nursing for a very vulnerable population. And number 3, retain the 2 seats for members of the public. One of these public seats is currently held by a law enforcement officer. Thus, the board would request that an additional seat be created specific to law enforcement. Forensic nurses work closely with law enforcement. Creating this specific seat will assure that law enforcement will always have a voice on the board. These proposed changes would create a 15-member board with critical thinking, educational objectives, program growth, and sustainability goals to benefit the forensic nurses and the state sexual assault forensic examiner program. Maine has been a national leader in this specialty, and the board would like this to continue. An additional bonus is that there is no fiscal note to these proposed changes. All members are volunteers. Thank you for your consideration, and I'm happy to answer any questions you may have.
Thank you, Ms. Thornton. Any questions for Sherry Thornton? Seeing none, thank you for being here today.
Thank you.
Next up is Elizabeth Ward Saxel. Welcome.
Good afternoon, Senator Claxton, Representative Meyer, members of the committee. I'm here on behalf of the Maine Coalition Against Sexual Assault, as well as Maine's Children's Advocacy Centers in favor of LD 783. If you have questions about the SAFE program, you can talk with Representative Holly Stover, who used to oversee the program at the Department of Health and Human Services. One of the core services of sexual assault support centers is to provide accompaniment for survivors who choose to have forensic evidence collected by healthcare providers. In the mid-1990s, these advocates identified 3 issues with the standard of care. Survivors were experiencing long waits in ERs for ED doctors to do pelvic exam portion of the kit. The care survivors were receiving was often not trauma-informed, and when there were often issues with the quality of the evidence that was collected, like breaks in the chain of custody and so forth. During that same period, several states were starting sexual assault nurse examiner programs, which were intended to address these issues. These specialized training programs you've heard a little bit about, and MICASA was enthusiastic. So we wrote a grant to develop the SAFE program in Maine. Over 2 decades later, the sexual assault forensic examiners represent the gold standard for the care for sexual assault survivors. The program, which is now housed within the Department of Health and Human Services, is advised, as you heard, by the Sexual Assault Forensic Examiner Advisory Board. That's more or less in the same form that we proposed it in the late 1990s. We appreciate the board's intention to make changes to improve its ability to undertake its important charge. And I just want to note that while I believe DHHS will not be here in person, from what I understand, they did say they were going to offer written testimony and support. One additional thing, I just want to do something a little unusual and thank you for your vote ought not to pass just a minute ago on 888, which was our funding bill. And of course, the reason why you voted was because you voted unanimously to support us within your budget proposal. So gratitude for that. I'd be happy to answer any questions on the bill we're actually supposed to be talking about, and would be welcome to be here for the work session if you need me.
Thank you. Questions for Elizabeth Saxel? Seeing none.
Thank you.
Thanks for being here today. I don't see any other folks in the queue ready to deliver testimony. So I would ask the committee if there are any requests for additional information for our work session. Seeing none, I will close the public hearing on LD 783. That concludes our public hearings for this afternoon. I would turn to our analyst for any additional work on our agenda. She is telling me none. I would entertain a motion to adjourn.
I move we adjourn.
I second it.
Moved and seconded. All in favor? Thank you very much and have a lovely weekend. We'll see you Monday.
Have a good weekend, everyone.